Good afternoon, everyone. It's wonderful to see as many of you as are here today. We may still have a few people who are straggling in, and if they do, we'll, in our organization, particularly in some of our management meetings, if people are late, we have them do the happy dance. So it reminds them that it's a privilege to be here, and it reminds them that they're late. So I'll leave that to you about whether or not we ask anyone to do the happy dance. I won't single anybody out. But welcome and thank you for attending the Open Minds Across Canada Health Symposia 2013 at Mental Health Sciences. My name is Kareem Mamdani, and I'm the President and CEO here at Ontario Shores. This is the third year Ontario Shores has been one of the host sites for this initiative that's been led by Healthy Minds Canada. It's a national charitable organization that raises funds for mental health and addiction, research, and education. Since 1980, Healthy Minds Canada has funded close to 400 research projects in 42 teaching hospitals and universities across Canada. To get the valuable information gained from this research to the people who really need it the most, Healthy Minds Canada hosts workshops and symposia across the country and has published the When Something's Going Wrong handbook series. Valuable resources to help families, teachers, and employers manage mental health issues in their respective environments. Ontario Shores is pleased, once again, to be one of the host communities for the Open Minds Symposia. Ontario Shores is a public teaching hospital providing a range of specialized assessment and treatment services to those living with complex and serious mental illness, including geriatric care and dementia. Exemplary patient care is delivered through safe and evidence-based approaches where successful outcomes are achieved using best clinical practices and the latest advances in research. Patients benefit from a recovery-oriented environment of care built on compassion, inspiration, and hope. Our organization is dedicated to education, research, and helping the advancement of mental health systems to improve access for all and to remove the stigma that often acts as a barrier to those needing care. I have to say I'm especially excited to see this year's focus, dementia, the latest information about prevention and treatment. It's a timely discussion with the recent addition of Dr. Arlene Astell as the Ontario Shores Research Chair for the Community Management of Dementia. I know Dr. Astell will be speaking a little bit later, and we are so pleased that she's joined us and look forward to her bringing her passion and her expertise to support those living with dementia and their families. Many of you here today work directly with seniors, and you know the prevalence of dementia. We have an aging population here in Durham, and more than ever, people are living together longer, adding to the risk of dementia. Statistics show that in 2011, there were 717,000 Canadians living with a cognitive impairment, including dementia, and almost 15% of those were over the age of 65. The physical and psychological toll on all, including families and caregivers, can be staggering. Many of you see this through your work and within your own families. But as you will hear today, there are many great programs and supports, as well as concepts that can help those with dementia maximize their abilities. I hope today's event will provide new information, spark new connections, and inspire you as we work together to improve the lives of those with dementia and the people who support them. I want to extend a sincere thank you to everyone who supported the planning for this event, and a special thanks to all of our presenters who are sharing their expertise with us today. Thank you again for attending, and I hope you enjoyed the symposium.
So those are wonderful opening remarks by our CEO. Thank you, Kareem. I have only a few remarks to add because I know we want to get to the speakers, the real main event of the day, as quickly as possible. But I think also we should tell you a little bit about Healthy Minds and also a little bit about where you can find further information. So, excuse me, Healthy Minds and its partners are hosting symposia at this time across Canada in a number of cities: Vancouver, Winnipeg, Hamilton, Toronto, here, Timmins, Kingston, and Ottawa. In terms of social media, we'd appreciate it if you help us build awareness of today's symposia, and if you're able to tweet about us, there is a hashtag that we can give you. In terms of housekeeping items, I should tell you there'll be a break at 6:10. There will be refreshments across the hall in the conference place, and there are washrooms just to the right of the entrance to the conference place. As a further housekeeping matter, there's evaluation forms in the back of your package. It's very important to us that you fill out those evaluation forms and leave them for us at the end. The evaluation forms are on the yellow paper. Today's event is being webcast, unfortunately not in such a way that the persons on the other end of the webcast can ask questions, but they can see the webcast, and the presentations for Healthy Minds, generally speaking, are available at www.healthymindscanada.tv. Kareem has already given us an overview of the issues related to dementia. More broadly speaking, because Healthy Minds, we've chosen dementia. Different sites choose different topics. Healthy Minds is all about mental health and the many different topics contained therein. 1 in 5 Canadians may be affected by a mental illness each year. The cost of mental health to our healthcare system and to corporate Canada is estimated to be over $50 billion annually. The good news is there's a good deal of research going on. As Kareem's highlighted, it's a strong anti-stigma movement, and we hope that we can make things much better for folks suffering from mental illness in the years to come. You will notice that there are some inserts in your package that can provide you with more information with respect to today's topic specifically, that is to say dementia. Healthy Minds Canada also has a video about the work that they do and their sponsors, and this can be found on YouTube. And if you want any of these particular URLs or these addresses or further information, feel free to approach me at the break or approach me afterwards. So, without further ado then, we'll go on to our first speaker of the day. This is an individual that we're all obviously delighted could be with us today. She has to head off to Vancouver later in the evening, but she's going to be here to give this presentation now. Dr. Arlene Astell is a joint Ontario Shores University of Toronto chair, in this case in the community management of dementia. I should tell you just very parenthetically, we're very lucky in the Toronto area that we have a good deal of research going on in the area of dementia, a lot of pharmacotherapy research, a lot of basic brain research. But the issue of how to manage folks in the community is something quite new, and it's a gap that we very intentionally wanted to fill at this hospital, thus the joint chair. She is an associate professor at the University of Toronto and a full professor at the University of Sheffield, as well as an honorary professor at the University of St. Andrews. Arlene is a psychologist by training. Her PhD is in the area of dementia. She works on developing creative interventions to support people to live and age as well as possible with dementia and other conditions of aging. And she's involved in a large number of projects, as you might expect with somebody holding a chair, having to do with these exact topics. She is here to speak to you today about can you live a good life with dementia. So I'm delighted to introduce Dr. Astell.
Hi. Well, I don't know what to say now. I feel I've got a lot to live up to. First thing you'll spot is I'm not from round here. And that's really important because, later on in my presentation, you'll be hearing some other voices, and they're also not from around here, and quite a lot of them are Scottish. So you need to get your ears tuned in for the different accents. What I'd like to do just before I start is to say what a great pleasure it is and an absolute delight to be here, and also for this to be my inaugural keynote as the Ontario Shores Research Chair. I've been in the country precisely 6.5 weeks, and so it's been a very busy and fast-paced time, and I'm really trying to get established with a whole exciting program of research based in the community around supporting people to live well when they get a dementia diagnosis. And so the way I'm going to do that tonight is to introduce you to some of the projects that I've been working on, and hopefully encourage you, first of all, to believe that this question has a positive answer, because I really believe it does, and I believe it's essential, actually, that we aim towards people having a good life once they have a diagnosis of dementia. I've worked in this field for over 20 years, and on the one hand, I'm delighted with the growth of interest and awareness and coverage that the issue now gets. When I started out as a PhD student, nobody was interested in dementia, nobody was doing research on it. I was actually advised at one point it wasn't too late to switch to something else, but I've always been absolutely fascinated from my early days working in a psychiatric hospital in the UK. And as I said, now the situation is very different. There's much more awareness, there's much more funding, there's much more coverage in the media. My concern is that most of it is very negative. And I actually think that's not helpful for people who get a diagnosis and their families. I also think it's not helpful for attracting people to want to work in the professions to care for people who have dementia. The point is, as Kareem was saying, the numbers are growing. This is across certainly the Western world, but also in developing countries now. And we need to face up to this. It's like cancer was 20, 25 years ago. We've got to stop hiding our head in the sand and saying, oh, it's a terrible diagnosis, let's not dwell on it. Actually, people have to live with this. Every day, hundreds of thousands of people are getting a diagnosis. They've got to live with that for the rest of their lives, and so do their families. And so we need to take an approach, we need interventions that enable them to do that as well as possible. And so that's what the focus of my research is. There's also another theme, which we'll pick up very quickly, in the types of projects I'm talking about tonight. But I would say that my research covers everything from people at the point of from the point of diagnosis in a memory clinic. In fact, some of my work is about trying to recognise people before that stage, but also we do research right through to the end of life, where people are perhaps no longer able to speak and convey their needs any longer, and we work with families and carers in organisations to help them with manage that too. So I have a very broad range of interests, a lot of experience over a lot of years, which I'm really excited to be bringing here. And one of the things I hope is that you'll see something of interest tonight, something maybe you didn't know, you hadn't thought about before, or something that makes you think you would personally like to be involved with the research program that we're going to build. And if you are interested and you want to know more about what we're going to do, you can contact Tracy Henry, who you emailed to register. And as I say, I'll be perhaps coming back to you to say, right, okay, let's get going with this. Okay, so I said that I'd done a lot of work in Scotland, and I want to show you a photograph which was taken in June. Now, this is an event that we were holding in a project, as part of a project called Cobalt. And this was done in Edinburgh, and you'll see there's lots of people in the room, and they're all sitting at tables looking very intent, which is a good sign of a good workshop. They're all busy. I'd like you to notice the gentleman there on the right with the black shirt and the grey hair. That's Brian. And Brian has an important part to play in my presentation. And this is him, as I say, participating at the Cobalt event. And I'd like to tell you a little more about him. So this is Brian's description of himself. He's 63, and 3 years ago he was given a diagnosis of dementia, Lewy body and vascular dementia. And you'll notice this as Brian's blog, and as well you'll also realise that was a year ago, so it's another year on. Brian writes a blog for the Cobalt project, and this was the first one he wrote when he joined the project last year. And I would really, really encourage, if you don't do anything else after this talk, is to look at the blogs on the project website, because Brian very honestly and openly and quite movingly describes the ups and downs over the last year, his life with dementia, and his involvement with the project. Now, why am I introducing you to Brian? Well, he is important for illustrating the first part of my talk about what it can be like to live with dementia. Now, what I'm going to show you next are some of his slides, because at that event that I just showed you, Brian was one of our speakers. And so the next thing you'll see are some of the slides that he presented. So he gave people his background, and you can see he saw the world a bit when he was young. You might notice he has some nice, interesting tattoos, as common from people in the Navy. He worked in care, and you can see he worked as a care assistant, a care officer, and then he was involved in training. And that's really important to know, and he felt that was really important to know, because when he was diagnosed, he knew what to expect, because he cared for people who had dementia. And he knew that that was it then, that there was nothing that could be done. People with dementia, it's all downhill, they can't do anything again, there's nothing to offer them. That's what he believed, because that's what he'd always been told. So for him, he had a series of events, he had a stroke and so on, and then he got this mixed dementia diagnosis, which isn't the most common, but for someone who's younger, often it isn't an Alzheimer type picture, it is something else. So this is Brian today. And he, as he said, he's had been someone who used technology in his daily life before he was diagnosed. Now, the reason the hoists are on the bottom, that was in his care job. But he was someone who was using technology, his phone, PC, TV, like everyone in the room, I guess. Yeah, we all use technology in our everyday lives. And this was important to him because once he got diagnosed, he just couldn't use technology anymore. As he says, anything with a plug. His wife had to stop him using the microwave because he kept putting things with the tinfoil and so on. But he actually got to the point, and it's partly a characteristic of the dementia he has, where the computer would actually freak him out. He couldn't have it sitting there. He couldn't be in the room. And he was very distressed by this, and he actually got very depressed for the first couple of years of his diagnosis because he felt so useless. He was still young, and he felt that everything had gone away and been taken away from him. And one of the reasons was he believed that you can't learn anything when you have dementia. So once it's, that's it, it's all gone, therefore it's all downhill. But he now feels that that's a misconception because in the time he's been in the Cobalt project, he has relearnt a number of these things. So now he's allowed control of the remote, which is a big thing in a lot of houses. He started using a computer again. He's got the microwave sussed, he doesn't set the fire alarm off, and he's using the phone again. But interestingly, one of the things that was really new to him was a mobile phone. It's actually a smartphone. He's got an iPhone, which his wife bought him about a week after he joined the project. And I'll let you now hear Brian describing his life since he's been in the project, which I hope is going to work.
Then we call it the miracle. Into our lives came Dr. Maggie Ellis. Dr. Maggie, as she's known in our house, offered me the opportunity to be part of the Cobalt project. Really, if I thought Sharon and Jennifer were saints, Maggie was a super saint, but the patients were too. In a matter of weeks, she restored my confidence in technology. And at this point, my wife bought me an iPhone. The iPhone lived in the box for the next 2 weeks till Dr. Maggie came back. And through her patience and skills in teaching, she taught me how to operate the thing. Just quickly, these are the things I use the iPhone for, and basically everything in my life. I'm in contact with Sharon anytime I'm away. I use the internet for research, mostly dementia research. I like the sports results, watching TV on it, keeping appointments in it, keeping a daily journal, Facebook, believe me, emails all the time, travel information. I'm able to buy tickets online now. I can travel independently because I have the phone with me. I know there's somebody at the other end of the line right away. The sat nav, I love it, but Sharon hates it. Google Maps, I've always been interested in places all over the country, all over the world where I lived, the Navy, and I like to look at them again. And using apps, Maggie taught me how to use apps on the phone, and I downloaded some wonderful stuff. The daily journal, since my diagnosis, I have handwritten, and Dr. Maggie helped me to download a journal onto the phone. So I keep that too, every day. Everything goes into the journal, whether the weather is, how I'm feeling, what I'm thinking, etc., etc. As I said to Facebook, it is for a bit of fun, but it's a good way of keeping relatives abroad in touch. The photographs and videos I could take on the iPhone, I put into a collection on my desktop, but I'm now a proud user of a laptop, and Dr. Maggie's taking me through that as well. So, highlight the possibilities. It has made me independent travel possible. It has increased my confidence. It's given me the ability to purchase online with supervision. I do organise photographs, and I'm more open to other new technologies. This led to an increase in curiosity and activity on a daily basis. The despondency was lifting. I had a real increase in my curiosity. I am now eager to read about anything new and will search for information until my curiosity has been satisfied. Sharon thought this was a good time to buy me a Kindle. That goes everywhere with me too. I don't read conventional books. I'm unable to take in, I keep in what I'm reading. With the Kindle, I can drop off to sleep and go right back to the line I left it on. There's no more despondency. I listened to all the horror stories about dementia being a terminal illness. 8 years lucky enough that you've been diagnosed. I don't think of it that way now. I live for today, my wife and family, and everyone around about me. I enjoy life. I have now joined the Scottish Dementia Working Group. I am on the committee there, and I go to Glasgow at least once every 2 weeks for meetings, and I went to various other committees through that, and I'm enjoying every minute of life. I really am.
Okay, I hope you got the gist of that. Sorry about the quality. I mean, it was recorded from a bit of a distance. Two things I really wanted to point out. I mean, Brian, I think, is extremely eloquent in describing how the iPhone, etc., has helped him. He mentioned the Scottish Dementia Working Group, and I'm not aware if there's anything similar that operates either locally or provincially or whatever, but I think it's a really great model. And in Scotland, it started in 2002, so they've already had their 10-year anniversary, and it's basically an organisation, a committee of people who have a dementia diagnosis, and they have very good contacts with Parliament, and they're very influential. Brian, after again working with us, they invited him to join the committee, and I think next week or this week he's speaking in Malta at the Alzheimer's Disease International Conference, and as he says, he gets to Glasgow every couple of weeks, and he books the tickets himself, and off he goes, perfectly fine. And this has all been happened in the last year. The other thing I would say, he kept talking about Dr. Maggie, and that's the lady sitting, the first two, and the next lady is Sharon, that's his wife. Maggie is someone I've worked with for 10, 12 years now, and she's one of the people that I'm hoping to get to come over to help me with some of the work that I'm planning to do. We've had a long association, and as Brian said, she's quite a star. So hopefully she's one of the people who'll be coming to do some of this work. Okay, so you should have also now picked up on that the theme here is about technology. And you might be sitting there thinking, well, yeah, that's all very well, but, there's other really more important things. But I actually think that having things in life that are meaningful, that you can achieve, that keep you going through the day. A lot of the strain has been taken off Brian's wife, for instance, because now she's got his phone, he can use it. She doesn't have to worry all the time where he is and what he's doing. And I think technology has a huge amount of potential. There's lots of currently available devices, and you don't have to have really clever, fancy smartphones. There are lots of simpler ones that can have reminder functions and GPS and so on. There's also the potential, and Brian, I know, okay, this is a case study, but Brian demonstrates that there's potential for people to relearn old skills which is fantastic. I mean, ideally we want to prevent them losing them too quickly, but if they can relearn them, that's all the better. But also to learn new ones. And I think there's opportunities to support other aspects of life for people with dementia. So what I want to tell you about is some other research using technology. And Brian might be an unusual example. As I say, his type of dementia isn't the most common. Typically, there's more people with an Alzheimer-type presentation than anything. But the potential of using technology is something that I've been working on for about 10 years with people who have primarily Alzheimer's, although we tend to let anybody who's around who wants to participate to come and join in. So I want to tell you first about Circa. Now, Circa is a project that was developed to support communication. And I've been using this quote probably since I was a PhD student, because I actually think it's really sums everything up. Because humans are social beings, everything we do is based around communication and interaction. And I think this quote from Azuma and Baylis, where they suggest that, the decline in communication might be the biggest or the most devastating problem that happens in dementia. And I actually hear it over and over again. When you ask people what the problem is, it's communication. We don't understand, the person doesn't understand, there's a lack of communication, it's really hard to communicate. And this has massive consequences for people. So we set out to develop an interactive touchscreen system to support communication between people with dementia and caregivers. Now, I realised I took the dates off this because I didn't want you to think it was something really old. But actually, we started this work in 2001. Now, I'm sure you're all familiar with touchscreens, but back in 2001, you had to buy a great big touchscreen and take it round with you and attach it to a laptop computer separately, whereas now I'm sure there's a few touchscreens in the room, some tablets and some smartphones. Back then, this was cutting-edge technology that you had to buy. Okay, so why we wanted to do this, as I said, communication is really fundamental. And for people who have a dementia diagnosis, losing their ability to communicate effectively really impacts their whole experience in many different ways. It affects their ability to interact in the social world with other people. They lose their confidence because they can tell they've said something that wasn't quite right by the look on other people's faces. Often people will become, depending on the type of dementia, it can affect the types of things they say, and it affects their whole personhood, their whole identity. It's really important for families as well, because communication is at the basis of relationships. And often people find it really hard to say, I don't actually know what to say when my mum says this, or my gran says this. How do I respond? And some of these issues are so fundamental, but we see them over and over again, and they're all to do with the change in communication. And the third group I really believe it affects are staff in caregiving organisations, because we often require them to make relationships, caring relationships with people who, when they meet them, they've already got some communication problems. But we expect them to get to know them, to find out about them and form bonds with them, to enable them to give person-centred care. But they're trying to do that with someone who already has a communication difficulty. So we set out to provide something that would satisfy the needs of all of these groups. And as it was a research project, we had a certain set of parameters. But basically, all the idea was that the problem that occurs with people who have Alzheimer's disease is that they forget what the current issues that are being talked about, the topics of conversation. They're very good at remembering things from the past, but the current things are much more challenging. So we didn't want people to have to remember a lot of stuff while they're having a conversation. We wanted to maximise, this preserved memories from the past. We wanted to have something that was failure-free. In other words, you'll put people right off technology. I mean, I'm the first one to admit, we changed something in the house like the microwave or the TV. I cannot figure out how to do the programming or whatever. So, we all want to have something that's failure-free because it makes us feel stupid. That's no different if you have dementia. But actually, you're more likely to assume, well, it must be you because, you have dementia. And so we wanted something that people would enjoy and not experience failure. We wanted multimedia, so photographs and songs and so on. And we also wanted something that would be usable by lots of different people, that there was no right answer, so you couldn't get it wrong. In other words, you don't have to remember that this is your particular holiday to wherever it was, Niagara Falls in 1976, and who all the people are, because you could get that wrong. Whereas if it's just a picture of Niagara Falls, you could have a memory of when you went there. So So there's a difference, and the generic things are actually much less stressful for people. So it was using a touchscreen, no mouse or keyboard, because again, we realised, as obviously why they're so popular now, that that was a beneficial thing for people who weren't very computer savvy, and no experience required. So I'll show you an example of the content. So there are photographs. Now that's an incredibly old one. That would, for most people, that would be their grandparents or great-grandparents. But that's, pretty old. But again, it doesn't matter. You don't have to remember that. You don't have to remember. You could talk about your own experience of being in school or what it's like now. Or it doesn't actually matter. The whole point is they prompt a conversation. And anybody can have a conversation because pretty much everybody's been to school of some sort. There's also music, and when the music is playing, either you see a record of this type or a gramophone player, and then similarly when movie clips are playing, it's either it looks like a TV or it looks like a movie theatre. So the Hollywood movies, it plays like it's a movie theatre. And that was just to provide sort of appropriate context. Okay, because we're researchers, we did lots of studies comparing it, lots of every which way you can think of. We compared it with reminiscence activities that they would run in different care settings. We tried different things where we video recorded. We also put it into care homes to see how they could work with it. And I mentioned the project in BC because I thought if people here are interested in something similar, we could try and get something going. We've actually been doing that project since 2008. Trying to get local contents, and we've just got to the point where it's being tested. It took a long time, partly because we didn't get a huge amount of funding, and secondly because we uncovered a whole lot of really interesting issues around how to select the contents to meet the needs of all the different groups. So that took us a lot longer than planned. But I'm sure if people are interested, we could try and do something similar here, because most of the contents that are in it are very UK or /Hollywood oriented. Okay, so we made this and we thought it would be useful to support conversation, and this is some of the feedback we got from people with who have dementia diagnosis. They would say, oh yes, it takes you back, refreshes your memory, it's a good thing, it covers everything. And often they would make suggestions about what else they would like to see. But the main thing was that it supported them to have conversations. And I know from over the years of using this and taking it into care settings, not just in the UK, but in other countries too. I've even taken it in countries where they don't speak English, notably Bulgaria and Japan, and people can still respond and use it. They don't necessarily get all the references, obviously, but even just the interaction is quite engaging for people. So I'll show you a little film that just sums it up, and you'll see also that it's quite a large computer that we were using, as opposed to the little tablet.
Welcome back. For the 750,000 people suffering from dementia, there's no cure, and drugs only help to alleviate the symptoms. Well, today, there may be hope.
Yes, for today's Life Matters, we look at the computer programme which can help people regain some of their lost memories. And for one sufferer, Margaret Piggott, it's making a real difference to her life.
Our Scotland correspondent, Martin Geisler, reports on how looking into the past is helping people with the present.
It is a simple innovation designed to help those whose memories are fading. The Circa system unlocks areas of the mind which might not otherwise be accessible. It provokes nostalgia, a smile, and sometimes a whole lot more. Margaret has been in daycare for 5 years at a moderate to advanced stage. This is her first session with the computer. She's impressed.
I liked watching the Dundee street scenes and Dundee today. It reminds me of the happy memories I had when I was young.
The system provides a database of pictures, sound and video from years gone by. It's easy to use, and that's the beauty of it. The carer and the person with dementia work together. Seen some impressive results.
It's good to see people that are happy. That makes my job all the more pleasant, that people are getting something out of their day. If I can do anything, any activity, using different resources that makes their day better, well, they have a good day. That's basically what it's all about.
The project has the backing of the Alzheimer's Society.
I think reminiscence enables people to remember past events. People find it enjoyable, it improves their mood. Structured interaction is very important in developing relationships between people with dementia and their carers. And again, that will benefit their mood and other things in the longer term as well. So I think bringing those two things together is very powerful.
For people like Margaret, it simply brightens up the day. Martin Geisler, ITV News, Dundee.
Good stuff there.
Right. Okay, so now I hope you see there's another theme developing, which is about enjoyment, laughter. And I think that's another thing that's really fundamentally important, because we don't think very much about meeting those sorts of human needs, but actually not just engaging with people, but enjoying ourselves, having a time of laughter, of something amusing us. That's often not a high priority in dementia care settings when you're looking after a relative, but actually that sort of time to just have fun away from all of the other things is actually really invigorating for everybody and really important. And that was one of the things that we kept seeing, people just singing, having a good time, laughing, joking, very much here and now. As Brian said, he lives for today, he lives for now. But actually, that's perhaps one of the key things to do, have those key positive things here and now. So I showed you the reactions of people with dementia. Many of the families commented how they saw their relative back to their old selves. So I haven't seen my dad talking about that stuff for years, or he hasn't looked so animated, or, I never even knew this. I'd forgotten all that stuff about Mum. Before we were born, she did this, she did that. And, it's just really a way of reconnecting with some of those other things about the person and making the dementia recede a bit. Also, we found that's popular with staff because they could sit down and have a one-to-one with someone, which, of course, they never have time for, and they don't have to prepare anything. You can just sit down with someone and just explore it. You don't have to do anything else. You just switch it on and it's there, and you can just, for 5 minutes with a cup of tea, and you can just do that. And so it supports these positive one-to-one sessions. So we found, that's just the research stuff if people are interested, but we've done a whole load of stuff, basically looking at everything from the impact on caregiving relationships. I mentioned about generic contents. We're doing some stuff on diversity, which is the BC work, and also storytelling as a way of having conversations. But what I wanted to lead it on to is we wondered then, after we'd done this, if there were other possible applications of this sort of touchscreen technology. Because clearly people enjoy having, engaging with it. They didn't find it particularly difficult to use the computer, which was what we were always aiming for. And so we thought, were there other things that people with dementia could use a computer for that would be beneficial? And a family member had said to us, it'd be really good if you could find something that my partner could do to occupy himself while I'm running errands or doing other things, because that is getting to the point where I said, I don't want him to just sit in front of the TV. I can't read books anymore, but I'd like something that would engage him. So what we thought was perhaps we could make some games. Now, again, you're probably thinking, yeah, but, that's sort of obvious. But this was back in 2004 when we started this project. So it was before the Wii and which I know is very popular in a lot of places. In fact, a lot of the games we first made 2 years later did come out on the Wii. What we were aiming for was something that people could do that would be using a computer that would... Now, I'm very keen on the idea of reducing excess disability, which is where people are disabled more than they actually need to be, and dementia is a classic example where people, once you've got that label, then people assume you can't do anything. And I think we need to be challenging that at every turn. But what we wanted to do was something that people could use on their own, first of all. That's what we thought. Something that they could sit and do without someone sitting there saying, and now do this, and now you do that. So this is what we were aiming for. And we had two key questions. What will people find enjoyable and engaging? Well, that's a bit like asking, what will this room find enjoyable and engaging? Because everybody's different. We all like different things. But we thought we could maybe hone it down to a few sorts of things that people would enjoy. And also, how can we put people in front of a computer who are not computer users and enable them to sit there and have a failure-free experience that they can just do on their own? That was actually the bigger challenge, you probably realise. So, over the 3 years, we developed about 25 or more different activities. We were very lucky. We attracted a programmer who'd worked in computer games industry for about 10 years, and he wanted to get out of that and do something much more socially aware. But he had great programming skills and knowledge about games. And so we were able to develop lots of things quite quickly. Key point to mention is when I said we tested it with 60 plus people with dementia, we only worked with people who had a dementia diagnosis. So we didn't go to the staff or the families and say, what do you think people would like? We just took everything to the people with dementia and said, what do you think? Do you think you want this? Would you like this? Because we were very keen to get feedback as immediately and as quickly as possible. And to be honest, we learnt very quickly. If a game wasn't going anywhere, we only need to show it to 3-6 people. And if they'll give it, take that one away, I don't want this, or you can keep that, or, that's not for me, we knew that wasn't going to go anywhere. So we stopped developing those. And the ones that people liked, they would say things like, can I take that one home? And I'd like to show my family, and I'll just keep this for a bit. So people were very happy with the games that they liked. And we also interviewed them afterwards to get more detailed feedback. Okay, so this, what I'm going to show you here is some clips taken from when we were developing a game. You'll see it's a painting activity. And you'll see the first few people did it before it even had any backgrounds. This is really in development stuff. And what we were trying to do here, as I say, it was research, so we were trying to find out what cues or clues do you need to give to people to keep touching the screen. So you'll hear some funny noises, you might see things flashing and jumping around, and this is us trying to answer those questions of how you keep people interacting. And all of the people that you'll see, none of them were computer users beforehand, and also they're on their own in the room. We're sort of out of sight, and while they do this, sorry.
Hello, I'm still dabbing away here.
Oh my goodness, what a good job you made of that.
Okay, so you saw some of the reactions, a lot of intense concentration from people. Also, that lady there, I don't know if you noticed when she changed colours, she wiped. Totally subconscious thing. She's not the only person who's done that. But you can see as well, all those different people, and they didn't all have Alzheimer's. At least one had Parkinson's disease. But they were all attending a day centre, and you can see everybody was very engrossed. You saw them touching different bits. You probably realised the paint pots can move. It makes a noise. There was a button in the middle to remind people if they didn't touch it. And we found everybody was able to use it quite successfully. The range of people was a sort of a mix of abilities. I'd say none were computer users, and about 5.5 minutes. People would, perhaps some people would have done it for longer. In fact, some people did, but it seemed to be something that people could do on their own, and they quite enjoyed. So this is an example of a post-session interview, and this is a different activity, and you'll see it's a chimes activity. And this one, I think I might have remembered to put the subtitles on. So.
How was that?
Yeah, that's very interesting.
You like that?
That's good.
It's nice, isn't it? Yeah. I like the colours.
Aren't they?
Yeah, the colours are lovely.
Beautiful
So
colours.
you enjoyed using it again?
Yeah.
And did you find it difficult to use?
Once I got into the way of it, maybe I wasn't doing it right, but I was getting sound in that, and they were moving about.
Right.
Was that?
Yeah. So once you got used to it, you were fine.
Yeah.
Did you enjoy the actual making music?
I enjoyed listening to it and everything,
Yeah.
And then I was trying to see where what movements were
Oh, right.
going.
Okay. Movements. True. Did you find it difficult to remember what to do?
at times, and then I kind of kept going back here for a wee bit, whether I was right or wrong. I don't
No,
know,
that
but
is right.
I just kept kind of going back down there.
Kept coming back to the action
Uh-huh.
button. That's what you're supposed to do.
Okay.
To action. Okay, and last question. Do you think that this is something you'd like to do again sometime?
Aye, I wouldn't mind doing the kind of thing like that. It's relaxing.
Yeah. Yeah.
Is that right? Or
Yeah.
am I wrong? Or
No,
what?
no, I find it
Saying that?
relaxing as well.
I know, watching the movement and the colours where they're all going.
Yeah.
You're wondering, where's that one going this time?
Yeah.
Okay, so that's one of the participants, I think, quite able to describe, how she learnt to do it, how she remembered what she enjoyed about it. And so we did interviews like that after each session to see what people thought and whether they would like to use it again. The other thing I want to show you from this research was this issue about relearning. We heard Brian talking earlier about relearning to use devices and also learning to use the iPhone, so new learning. And you might be sitting there thinking, well, he's just an unusual case. But we decided in this project to look at learning, and 9 people very kindly let us turn up at their house about 3 days in 1 week. And you'll see with our slightly large computer and set it up. So you're going to see people's kitchens and various other bits of their houses. So we could look at whether they learnt, whether there was change over time. And this, again, is another game, which is ducks.
Okay. There you go.
It's like a fairground duck shoot. So have you noticed the different ways people learn to play it?
Touch it. That's it.
You just fire.
Yeah, just touch it. Just 2. Perfect. Perfect score. That's it. And then just touch the gun to shoot the ducks. That's it. Very good. That's it. You've got them all.
Oh, good.
That's it. Brilliant.
Again?
Yep, and they'll just come up again in a second. That's it. Off you go. Great. Good. Oh, look at that.
Okay. So, again, enjoyment, achievement, laughter. Also, there was learning. People did change. Actually, they got worse the second day because they were trying to do it too quick because they knew what was coming. And then they got better again on the third day. Not everybody, but you might have noticed there was a lady in the middle who didn't press the gun, she just pressed the side. And then she kept going back to there because it made something happen. I would say, for those of you familiar with the mini mental state exam, which is a measure of cognition, she was by far the lowest in the whole group when we started. And so she did have more difficulty learning specific things, but she was game to try anything. Sorry, didn't mean that. But she was prepared to try, the things. And it was very helpful to us. The reason we video is so we can actually see how people explore and learn to do that. So, as I say, people did sort of change. And the thing was, they all remembered that they played it. And as I said, they anticipated, which was problematic because when we made these things, they couldn't accommodate with that. I think technology could now. As I say, one woman told her daughter all about it, and another one got a staff member to come and they demonstrated it. And that was really useful for future work when I've actually taken it into care homes, and I will get the residents to use it, and then I get them to show the staff how to use it. So you might have been wondering, well, those are all people living at home. I said we did the other work in day centres and thinking, well, what about the people in the care homes? But actually, a lot of this stuff we've also done in care homes too. And I'll just show you a clip. There's 6 different games in the system at the moment, and you're not, unfortunately, going to be able to see them all. The ones that you haven't seen, you're going to have to guess what they're doing. But really, it's just to show you the potential for sort of interaction as well when people are playing the games with another person.
You don't realise that.
Do you hear it splashing?
Yes, I can hear it splashing.
It's like somebody jumping in the sea.
More ducks. Somebody got one of those ones. I don't even have to be here. No. Easy.
Who's eating all these ducks?
Does he play for Rangers?
I don't know, he's not got the blue strip anyway.
That's it, she's doing it. Oh, well done. Look at this. You've touched them all. Well done, Martha. Just follow that orange blue.
Ah, you got 2. You got 2 for the price of 1. I think I'll have to concentrate and see how you did that. 3-2. It's your turn again.
Really? But watch. Could you see that? If you touch this white ball, it plays a tune.
Okay, does anybody want to guess what the games were that you didn't see? The one with the gentleman, he said, does he play for Rangers? Yeah, it's beat the goalie. And then the one where the lady says, you got 2 for the price of 1. It's a coconut shy. And the other one, which you probably couldn't have, it was making a whooshy noise, is it's like a bubble blowing, and you can chase the balloons around the screen, and they make noises, and sometimes they get bigger, and they pop, and so on. But one of the things that was interesting in that study was when I got some students to code the videos, they came back and asked if it was okay to code for astonishment, because they said the care staff, often they were seeing this look, because these were, a lot of the residents were people who they felt didn't engage in activities and some of the group things, and they were quite amazed. Just the fact they were using the computer, but, actually that they were able to play the games and show them how to do it. So the balloon one, the resident worked out how to pop them before the member of staff did. She didn't know that if you keep pressing them, they'll make a popping sound. And as I say, sometimes they'll grow, which is quite funny. You try and fill up the screen. Quite a fun thing to do, especially as well with grandchildren and so on. It's the sort of thing that people can bring the family in and play together. Okay, so I'll just move quickly on. As I said, again, because I'm a researcher, this has all been written up, but for people who are obviously not interested from that perspective, it's really just to say that all this now has an evidence base. I think the point I made about that people with dementia cannot just be participants in research, they can be partners. And like I said, for me, it's about challenging these negative perceptions that people can't do anything. Okay, not everybody's going to be Brian, but everybody can be involved and engaged. And I think if we come from that perspective, then that really helps to move things forward. Because if you feel there's something that can help you, or help your relative, or if you're working in a service, help you to do that job better, then that's got to be a more positive thing than everything being, well, it's all just, feeding and watering people and that's it because they've got something that we can't do anything. I think that the evidence was that people can learn to do new things. When we started this work back in 2001, touchscreens were not everywhere. They weren't in supermarkets. They were not in our pockets. We just took them in and people could use them. And I think that's really important to note. And as I say, people can also be engaged. They can experience enjoyment and satisfaction and achievement. And who doesn't want that? You know, can you imagine what it's like to have dementia and never have the opportunities to do that because nobody has the time or nobody even thinks about enabling you to do that. Yet we thrive on those things, and it's no different when you have dementia. The problem you have when you have dementia is you can't necessarily achieve those things on your own. You need somebody to be with you or to provide that stimulation. But people certainly need it, and they thrive on it. So I hope I've convinced you that technology actually has a role to play. And I think we're really fortunate now in 2013. There is so much stuff that could be helpful. Now, I'm not suggesting everybody rushes out and buys an iPad and gives it to people with dementia. That's not going to work because, first of all, iPads have a lot of tricksy things in them that are not conducive to people who are not computer users. Having said that, I'm involved in a project with some people in the Netherlands where we've actually designed computer games for people, for the iPad, specifically for people with dementia, and I will be looking for people in this region who would like to help us evaluate those pretty soon, in the next month or so. But hopefully I've got you to think that maybe there is some potential in terms of the functions that are there that can support everyday life, like Brian was talking about, that technology also can provide opportunities for engagement and enjoyment. And even if you don't do it with technology, but how important engagement and enjoyment are for people who have dementia. I mean, there's more to life than being, clean and fed, to be frank. I mean, just think about it for 30 seconds, and we would all agree there's more to life than that. And I also think technology has a role in supporting communication relationships. Think about it. I would bet that pretty much everybody in the room has got a phone. Why do we have phones? To keep in touch. Because we communicate. It's so important. And again, it's really often overlooked. In dementia care, it's always only considered when it's a problem, when the person can't communicate. But actually, communication is fundamental of the human experience. So I asked you to think about whether you could have a good life with dementia. And as I said, I think it's an imperative. I think we have to strive for people to have a good life with dementia. The difference now, as I said, in cancer care in the last 20 years is just been transformed. Now when people get a diagnosis, they can have everything from dietitians, therapists, yoga sessions, massage, plan out, everything around their therapy. They can have coaches, they can have access to everything. I don't think we're anywhere close giving that to people with dementia, but we can't wait 20 years. Because the numbers are just rising, and the birth rates are falling in many places. So the caregiving, the generation to provide caregiving is not going to be there. We have to face up to the challenges, and I think technology has a part to play. But I think also changing our attitudes is an even bigger aspect of that. I just want to finish with some words from Brian. I always like to give people with dementia the last word. I hope this is big enough to read. This is from last Christmas. And I'll read it out, but I'm sure you can read it too. So he says, "Hello again, forgive me for the lack of blogs in recent weeks. I've had a number of bad patches with my dementia. I've also been very busy helping my wife, Sharon, in the run-up to Christmas. Take this morning, for example. The both of us were doing some shopping in our local supermarket. Sharon was searching the aisles for what we required. She would place an article in the trolley, which I was pushing as usual, and then moved on for her next selection. Meanwhile, I was quite happily placing anything and everything into the trolley also. When Sharon turned to make sure it was okay, that I was okay, she looked at the trolley, looked at me, shrugged her shoulders and started to laugh, and then began to replace the unwanted items. Since the day of my diagnosis, this is how she has coped with it. Never questioning, never angry, and never lying down to my dementia. She deals with it face on. She's led by example, and this is why I can be so positive about my dementia." And I don't think there's anything else I can say, so thank you very much. Yeah.
We're sort of bang on schedule. We could probably take a question or two for Arlene, for Dr. Astell, if there are some.
Yeah, hi, go ahead.
Hi, I'm Brenda, and I'm with the Alzheimer's Society here. We are so excited to hear that you're talking about living well with dementia, because that is the message that we see. We celebrate people's abilities and know that they can live well and talk a lot about self-management and all the things that a person can do. So we're so grateful to have you in our area, and we'll help you with whatever project you want.
Fantastic. That's exactly what I want to hear, because in Scotland, as I'd say over the years, we built up such a strong network of people that whenever we were doing a project, we've never had difficulty getting people involved. And I think that's the secret, is to do things that actually people need, but also that sends that positive message. Because, you know, I have to admit, some of my clips I've had for quite a long time, but I get people come up to me and say, I saw you speak in 2004, and I still remember that. And I think, to me, that's the important thing. It's not me that they remember. They remember seeing a person with dementia doing something they didn't expect and being positive. And I think, for me, you know, we have to have that step change, because it's not helpful to just be really negative about it. You know, we have to be much more realistic, you know, but it means good and bad, I think. So, yeah, I really look forward to working with you. Thank you. Does anybody else have? Yes?
My 91-year-old dad lives here in Whitby and is in a retirement residence. He has dementia. He doesn't have enough to fill his day. So I'm very intrigued by the program.
Mm-hmm. Well, I would be very, very happy to. I mean, one of the things we have learnt, and I said we had our computer in some care homes for 3 months, and basically I took it in, I did a quick training thing, and then I left them to it, and I asked them to keep a record. And there were some really positive things that came out of it, in that I think I trained 10 people in each home. I I ended up with more than 30 staff had used the computer, so that was good. You know, it had proliferated. And the sessions ranged from maybe 10 minutes to an hour, you know, so there was lots of use and lots of interest, where families used it too. But the biggest obstacle was still making it part of the daily routine, instead of it just being a special activity, which I'm not saying is a bad thing, but there was always the thing, that could be the thing, if we were too busy, that's the thing that drops off at the end of the day, you know, because we've got to rush about doing all these other things. And that's why I'm saying I think there needs to be a change in what the focus is, what the priorities are. And if there's people here who work in care settings, I'm sure you'd say, well, actually, it's not like that on the ground. But I have been, in the last 20 years, in many, many, many different care settings. And they're actually all very similar. You know, I've spent time in Holland, I've spent time, I'll say, in Bulgaria, where they have, you know, the settings are much more primitive than we would recognise. Their staffing ratios are much worse, but we managed to work with them to help them change their focus, to cut down the bits that was sort of time that wasn't positive for the staff, let alone the residents, and bring in more emphasis on making life more meaningful. And I think, again, that's part of this change to seeing what's actually important. Because having lots of people who are just sitting doing nothing, which is how it was when I first started, everybody was sitting in serried ranks with the TV blaring away. You know, I'm not sure how much further we've got in some ways in terms of recognising those needs, because those needs for engagement, interaction, enjoyment, even if it's for a short period, actually, certainly the evidence we've got, and some of it is anecdotal, but some of it is on our videos, is that if someone has a period where they've connected with someone, they've had some laughing, some singing, then that well-being is retained for the next sort of hour or so, and it's very positive. It's hard to measure scientifically, but it's definitely there, because it's that sort of positive experience. And we all enjoy it ourselves. So, like I said, it doesn't go away just because you have dementia. So. Yeah, well. Yeah, but no, I mean, that's right. There isn't enough recognition of what people used to enjoy and what they can do. And I think that is, again, where the programs need to really be looking at that, because so many people, and also just having some physical activity would do them the world good and maybe help their sleep as well. So, I mean, there's all sorts of positives, but absolutely, you know, if you let me know where they are, where he is, I can nip round with my computer and bag of tricks. Anyway, I better be quiet now.
Maybe we'll have one last question,
okay.
And just for the viewers, maybe if you could repeat the question.
Oh, sorry. Okay.
It's actually not a question. It's really just, I want to thank you, first of all, for inspiring such hope, and also inspiring a positive reflection for me. So several years ago, my grandmother was diagnosed with dementia right here at our memory clinic on Ontario Shores, and I just reflect back as I was watching your presentation on some of the time we spent using what my grandmother considered high technology. So I remember when she asked for a big flat screen TV, so when you went over to her apartment, we would spend half an hour to 45 minutes just watching. She would was so proud of the fact that she could use the remote control to click from the television to the front door. And she spent like half an hour, 45 minutes, just partially watching a program and partially clicking back and forth. And it was interesting, the communication, the conversation, and the interaction that was going on just with her doing that. But for her, that was her use of technology. So it's interesting that you were talking about the fact that it doesn't have to be an iPad, it doesn't have to be an iPhone, whatever it is. But anyway, I just wanted to thank you, because as you were going through your presentation, I was reflecting on some of those times.
Good.
And those were good times for her.
Yeah. Well, that's what I was hoping to encourage, just sort of people to sort of reflect and maybe think about some of the things they hadn't thought about before. But anyway, I'm going to hand over to the next speaker now.
Thank you so much. Thank you very much. So our next speaker is Stacey Hawkins. Stacey Hawkins is a PhD student at the University of Waterloo in the Aging, Health and Wellbeing program. And she has a master's degree in health and aging as well. She is a certified professional gerontologist. Her research interests are social dementias of caregiving for people with young onset dementia. And she recently presented the results of her MA thesis at an Alzheimer's conference in Boston. She's a clinical planning lead with Central East RSGS, or Regional Specialized Geriatric Service, where she is responsible for evaluating and providing recommendations regarding improvements to specialized services. And Ms. Hawkins is herself a caregiver to a parent with young onset Alzheimer's disease, and also an advocate for families touched by dementia. She's going to talk to us about living with a partner with dementia, social change, support, and resilience. Stacey.
Good evening, everyone. Thank you. Perfect. Bear with me. There we go. So thank you very much for inviting me here today to talk to you about the results of my MA research study, which I completed in the spring of 2012 at McMaster University. And as well, I'd like to also share some of my own thoughts about this topic and my experiences. But before I begin telling you about the research, I want to tell you a bit about myself, because I like to share. And because I think knowing who I am is helpful in understanding my perspective in the research I'm going to talk about. In no particular order, and you've heard some of it already, I'm a professional gerontologist, which is focused on the study of older adults. I also work within the health system in the area of health gerontology, which is a complex title to explain, but my role generally involves using research information and trying to figure out how we can improve those services based on that information. I'm also a PhD student at the University of Waterloo, and my research will be continuing on in this area, so I'm looking forward to my future dissertation and engaging with caregivers during that time. Additionally, and you've just heard, and perhaps most important to the focus of this symposium, I'm a caregiver to a person with dementia. So this role, in combination with my other roles, and I know there seems like a lot of them, informs the way I approach my research and my job. And in relation to the information I'll be presenting this evening, my role as a caregiver was instrumental throughout the entire research process, mainly because I was candid with the spouses I was talking with about my own personal experiences. So I'm excited this evening to share with you what I learned and answer any questions you may have about it. So we're all here this evening, I'm assuming, because we all have an interest in learning about and discussing dementia in a safe environment and a candid environment. So what each of us knew about dementia before stepping through the door here tonight may differ a little bit. However, I'm assuming we're all going to leave here having learned something this evening. Including myself. And hopefully some of these learnings will help to dispel some of the common misconceptions about dementia. And I'm all about dispelling misconceptions because I've experienced a lot of them throughout my journey. So this evening, I'll be talking about young onset dementia, which I'll explain in a little more detail in a minute. But before I do this, I just wanted to clarify some of the terminology I'll be using, because sometimes it's confusing and it always seems to be changing. So dementia itself is an umbrella term for a variety of different neurodegenerative conditions. And progression and reversibility varies by the type of dementia and between persons. Everybody's different. Including those symptoms and how it affects a person's everyday life. So we heard some of the common examples: Alzheimer's disease, vascular dementia, Lewy body disease, and there's many more. Now, globally, there's a lot of people in the world with dementia. Approximately 35.5 million people had dementia in 2010, and this number is expected to double in the next 20 years. Now, whether that's a result of population aging or we're getting better at diagnosing is a matter of debate. However, dementia prevalence among older adults in Canada, so persons over the age of 65, is around 9%, and there is comparability between Australia, the United States, and other nations. However, dementia is not a natural part of aging. There's a range of inconclusive and contradictory evidence about the aging brain, what's normal and what's not. And dementia is different. It's not a natural part of aging. So that's our first myth dispelled. What I've learned, however, is that when many people talk about dementia, they seem to think that it is an older person. They may think of an elderly grandparent whose memory has begun to slip. They may even think of countless television commercials featuring an older person constantly misplacing their keys or buying bags of limes. Has anybody seen these? Yes? Regardless of what that image is, many people seem to picture dementia as old age, which is reflected in some of these images. So these were just ones I pulled off of Google. These were particularly positive because they showed people smiling and they showed people engaging in social interaction. However, dementia is not restricted to persons over the age of 65. Few people seem to picture that dementia as a 40-year-old woman with a full-time job, maybe 3 young daughters who are still in school. So contrasting these images, this is how I picture dementia. So this is my family. This was taken a few years ago, and this is how I picture dementia. I'm a child caregiver, and I think of young onset dementia, which is simply put dementia before the age of 65. Now, among all those persons affected by dementia, there are a significant portion of people like me and my family who are experiencing this. So reflecting on these images and considering my own experiences prompted some questions. And because I'm a scientist, I like to ask questions. And I wondered, are these experiences the same as older adults and late-onset dementia? Now, certainly the images we see more commonly depict older adults, and this is actually reflected in what we know about young-onset dementia. There's significantly more research out there on late-onset forms of dementia. So as I mentioned, young-onset dementia is dementia before the age of 65. Now, whether that's a diagnosis or that's when the disease began depends. But the prevalence of dementia is estimated to be between 5 to 9% of the total population. Now, we don't have Canadian statistics on this yet, but this generally tends to be the agreement on what that is. In fact, dementia can affect adults as young as 30 years of age. Alzheimer's diseases tend to be considered the most common form of dementia among younger persons. However, there are other forms of dementia that are more common among younger persons than late-onset forms, such as frontotemporal dementia, drug and alcohol-induced dementia, and atypical forms of dementia or mixed forms of dementia. And just like late-onset dementia, many affected persons will rely on informal caregivers as their disease progresses. Now, caregiver is somewhat of an ambiguous term. I've found that it means different things to different people and different things to different researchers. Is it a set of tasks? Is it advocacy? Is it a role? Or is it just providing emotional and social support to a person? I consider it all of these things. To me, it's a relationship. And that relationship means different things to different people because we all have different types of relationships. What we do know is that the majority of informal care is provided by family members. And in Canada, 1/3 of those dementia caregivers are spouses. And that number is inclusive of all types of caregivers, so formal and informal, because sometimes we forget about the formal caregivers that help as well. So after thinking about all this, I reviewed the existing literature on young onset dementia relevant to this topic. And I won't go through all the nitty-gritty details, but what I found is that there was no qualitative research of young onset dementia spousal caregivers' social experiences from within the Canadian context. And when I mean qualitative, I mean no studies that actually had in-depth conversations with spouses. So this was alarming to me because there are known health benefits to positive social support and recreation and leisure in buffering the effects of stress, depression, etc. So that prompted another research question. What are the social experiences of spouses of persons with young onset dementia? And what's a social experience? So I defined it as a spousal caregiver's individual perceptions, so their thoughts, actions, and feelings about their social contexts, so a very wide net. And therefore, I wanted to actually talk to spouses to understand what these social experiences were. So I interviewed them. A total of 10 spousal caregivers living in Ontario agreed to participate in the study and let me interview them. 6 of those were females, 4 were males, and their ages ranged between about 42 to 66 years of age, so younger group. And all of them were currently employed at the time of the interview, although in varying degrees. Now, their spouses with dementia, ages ranged between 54 to 67 at the time of the interview. 6 had Alzheimer's disease, or a diagnosis of, and 4 had frontal temporal. However, many of these were considered mixed or atypical forms of dementia, so there was quite a bit of variability there. One of those spouses with dementia was still currently working at the time and enjoying it, and 3 were living in long-term care at the time of the interview. So analysis of the interview transcripts and my field notes from these interviews revealed 4 social themes relevant to social experiences, which the spouses discussed in detail. And many of these themes and experiences demonstrate, much like Dr. Astell was mentioning, that in fact there was a lot of positive social experiences. So I'll tell you a little bit about those. For example, all of the participants described various sources of social support they had. And this included persons whose caregiver's social network had continued to provide social support to the spouse in social activities. Now, they primarily spoke in terms of family and friends being continued sources of social support. And for example, Anne described how her and her cousins, who they played cards with once a week, continued to play cards with her and Stephen, despite the effects of the disease on his ability to play. So he'd misplay a card, and they'd just go on like nothing happened. And that never became a problem with them, and she appreciated that. Participants also talked about surprising sources of social support, so people coming out of the woodwork providing unexpected support to them. One one participant in particular, Nancy, who was a recent immigrant to Canada, and she had 3 sons under the age of 10, described that although she didn't have strong familial support here in Canada, that she had an outpouring of support from the members of her church. For example, Nancy talked about how her family's adopted grandmother, as she put it, had taken her boys to a theme park for a vacation, because it's something they never really got to do anymore. She also described how other church members had surprised her at Christmas time by coming over to their home and decorating the outsides of their house with Christmas lights, which the boys loved. All of the caregivers also discussed giving up activities in favor of new activities that they could participate in with their spouse with dementia or that fit better with their schedules. For example, Pete described how he'd given up a lot of recreational activities like cycling and running in favor of activities he could participate in with his wife, Rachel. And one of these was take a nightly walk from her long-term care home to Tim Hortons to get a cup of coffee and sit and talk together. Or looking at tabloid magazines and photo books and laughing and discussing the pictures together. All of the spouses also talked about adapting and maintaining social and recreational activities, which involved adapting existing activities or making changes that would allow for participation in those activities. For example, Joni discussed how she'd changed her curling league so she could play in the early evening, which was easier for her to find someone to come in and sit with Robert while she did that. Also, William talked about how he'd taken up lawn bowling with Elizabeth, his wife, because it was close to the house, it was easy for Elizabeth to play, they could do it together, and the members of the lawn bowling club were welcoming and inclusive. All of the caregivers also talked about efforts on the part of the caregiver to continue participating in previously enjoyed social activities or recreational activities that they could do together. For example, Henry talked about how, as a family, they continued to go out for dinner on Friday nights with his wife and his son. And they continued to work together to prepare meals together on the Saturday nights in what he called food challenges. So they'd pick a different cuisine or a different way of eating, and they'd try to make a meal together as a family. About half of the caregivers also talked about the idea of taking one last trip together, one big trip. Now, this was more frequently described by people who like to travel. And one of these was Anne, and her husband were avid travelers. And she described how when he was first diagnosed, she said, well, we usually go in the summer for a trip, but we're going to go now. And it was the middle of winter. So they went on one big last Mediterranean cruise together, which was about 3 weeks, and they really enjoyed that. Lastly, the caregivers described certain social spaces as being safe spaces. And these were spaces that they felt they could talk freely, not worry about how their spouse with YOD was perceived, or feel as though they were not being judged by other people who maybe just didn't understand. For example, Pat described how she'd struck up a friendship with a woman she'd met at a support group. And because weekends were difficult for them, they decided to get together and sort of double date once a week at each other's home. And they'd order in food, watch movies together. And there wasn't this fear that either of them didn't understand what was going on or how their spouse was being perceived. Additionally, it was also perceived as being enjoyable for both of the spouses with dementia. They were still able to communicate with one another even if it didn't make sense to them. So the results of this study demonstrate to me that social experiences of spousal caregivers are highly information-rich aspects of the overall caregiver experience that extend beyond the negative impacts I frequently see described in the existing literature. They include many positive social experiences we don't always hear about in the news or in the media, such as taking up new recreational activities, adapting old activities, or becoming closer with friends and family. The research also demonstrates that the importance of social and recreational activities for both the person with dementia and the caregiver. For example, participating in community caregiver supports, like support groups, which many of the participants did, or self-initiated efforts to just get out and keep active and keep enjoying themselves. So, it's evident from the preceding analysis that peer support can become an effective form of social support for spouses and the person with dementia, particularly social interaction with other caregivers who are experiencing life with someone with young onset dementia. And that was evident in many of the persons I spoke with. For example, many of the caregivers described how some support groups that primarily consisted of persons with late onset dementia or caregivers of were sometimes criticized for not having information relevant to them that they could relate to, or that they just didn't feel comfortable talking to other people about. However, many of them ended up creating their own support groups. So they met a few people and through networking ended up creating external support groups with just those persons. So they found their own way to adapt to that. Also, there was apparent technical proficiency with all of the participants. And this meant that many of the spouses I interviewed had connected with other caregivers via the internet through telephone or web-based peer support, email, message boards, a whole wide range of things. And this spanned people within urban centers as well as in rural areas. One gentleman lived on a farm about 3 hours from a main city, and that was his way of interacting with other caregivers, was through the internet. So my closing thoughts. And this is largely my personal opinion, but it's also sort of backed by these experiences I've just explained to you tonight. We need to start to move past the perceptions and expectations related to dementia that we hear about, and we need to move beyond the misconceptions. For example, this is my mom early in her journey when she was first diagnosed with dementia. At the time, I was scared she would one day forget me, because that's what I expected dementia would be like, being upset that she didn't know who I was. This is what I expected, at least according to Hollywood films, and you probably know which one I'm talking about, and popular novels. Now that my mom no longer does recognize me, at least in the way that she used to, I sort of laugh at these earlier expectations and dismiss them. Primarily because I've learned that focusing on my expectations regarding my mom has not been entirely useful, because they are expectations I have no control over. Further, focusing on other people's expectations of what a person with dementia should like can be a bit disheartening. Rather, myself and what many of the caregivers I talked to described is that focusing on spontaneity, laughter, playfulness are far more enjoyable aspects of my relationship with my mom and their relationships with their spouses. For me, I learned to abandon my and other people's expectations, and I had a better relationship with my mom as a result. For example, I no longer worry about the content of what me and my mom talk about, because it never actually makes any sense to anyone else listening. So I've been able instead to focus on the process of talking, which is actually quite enjoyable and liberating when you don't care what you're saying. So in summary, it's about the content, and it's not about the content, it's about the act of having the relationship and the fact that my mom is engaged, she's enjoying it, and I'm enjoying it. So my take-home message, and probably reflective of Dr. Astell's, is that dementia is not all that bad. There are some bright spots that come streaming through the journey. And one of these moments for me happened right here at Ontario Shores, where I spent quite a bit of time with my mom and my dad and my sisters. And one of those was sneaking my mom jubes into the unit, which you're not supposed to do, and spending time outside of the park in the outside of the cafeteria. My mom taught me to look and try to find the positive part in all situations and experiences. And dementia has taught me to make the time to appreciate those moments whenever they appear, because sometimes they catch you off guard, as well as appreciating the close relationships I have with my family now. It's strengthened my immediate family. And I perceive it'll still be strengthened later. So thank you very much.
Thank you very much.
Yeah.
We have a few minutes for questions. If anybody has questions for Stacey.
They can be personal questions. I won't scoff at it, I swear.
Are you going to tell us how you got the jujubes in?
No, don't share that with anyone.
Yes.
Stacey, I seem to get a theme about the proactivity of caregivers
Mm-hmm.
early. So, was there any indication of what prompted them, or what was in their character, or their education, or what led them to react quickly and react positively, take control of the situation, as much as you can? Repeat the question.
The question was, the caregivers described in the study seemed to be proactive in their response to the diagnosis. It seems that way here, but about half of them, they were quite well adept at finding strategies to adapt their situations. Some of them weren't at that stage yet, and some of them it had been some sort of big crisis for them. Like they hadn't really thought about the diagnosis and made any plans, and then suddenly they had to make some plans. That being said, there were quite a few that were natural. They were outgoing people. They were advocates, and some of them that still today are advocates. And it's just it was part of their natural character. But for the most part, I think most of them it was learning how to be adaptive. And from what you've seen, a lot of them did get there. It took some time. Does that answer your question? Yeah.
I was looking for clues. If there are clues as providers of service that we look for and help launch people through that opening stage.
Including the biggest one, I didn't talk about it here, but it was during that early stages, including the person with dementia and their spouse together. A lot of them talked about, and I didn't say it here, about how they would have liked a group where their spouse could come with them and be engaged in the conversation as well. So I think that might be the key to creating that sort of adaptability and that proactiveness early, realizing that they can do it together. They just need other people to realize they can. Is that good? Thank you.
Okay. Well, if there's no further questions, first of all, we have some gifts for both Arlene and Stacey.
Oh.
Some thank you gifts. These are bags filled with solid gold bars.
I'll put my jubes in it. Thank you very much.
Yeah, we'll use the proceeds of this evening, I think, to purchase a jujube scanner, which clearly we need at the entranceway to the geriatric dementia unit. You're on that, right, Sheryl?
Right. And on a very serious note, it does pose a choking risk. I just have to put that infomercial in. So I forgive you, Stacey.
The truth is, the staff confiscate those jujubes and have jujube parties, I think, subsequently. Yeah. So we have a 20-minute break. There is some very tasty stuff across the hallway for you to eat.
Most days I feel like.
All right, let me see how many people are left. All right, welcome back.
Fighting winter with a snow shovel is like cutting your lawn with a pair of scissors. Don't just stand.
And I think we'll get started. So we have a wonderful second half lineup for you today, beginning with Dr. Arlene Fischler, who's going to talk about, as you can see, the treatment of behavioural and psychological symptoms of dementia on an inpatient unit. You've got Dr. Fischler's bio, I think, in your in your package. Dr. Fischler is a colleague and a wonderful geriatric psychiatrist and wonderful partner in our enterprise here at Ontario Shores. He's also the medical director of clinical informatics and has a real passion for quality and reducing variability and improving outcomes in care, both in geriatric mental health and in other areas. He's formerly the medical director of the geriatric psychiatry program. He's very involved in education and community awareness and the university processes with respect to geriatric psychiatry, and is just a great staff person and extremely knowledgeable in this topic. And I'm just delighted that Alon has agreed to talk to us today about this topic.
Thank you, Phil, for that very warm introduction. So when I was asked to give this presentation on the treatment of the behavioral and psychological symptoms of dementia on an inpatient unit, I asked who's going to be in the audience, because typically when I give talks, it's to people that are in the healthcare field, or it might be residents or medical students, and I was told it's going to be people from the general public. So I tried to think about what is going to be interesting for you to know about the treatment of the behavioral and psychological symptoms of dementia. So to start, I'm hoping to give a bit of a background about what dementia is and provide you with some interesting information about the different types of dementia, risk factors, how you can try to protect yourself from developing dementia, and then we'll go into some of the more details about how we can treat some of these distressing symptoms in an inpatient unit. So as Stacey said, dementia, it's not a specific illness. It's a syndrome, right? It's the development of multiple cognitive problems. Memory is usually the biggest problem that's affected, but it can be all kinds of cognitive problems like language skills or being able to solve complex problems, what we call executive functioning, or visuospatial functioning, the ability to navigate in three-dimensional space. It has to cause impairment in functioning. So it's not enough just that you have memory problems or cognitive problems. For us to consider the dementia, it has to cause some significant impairment in either your social life or occupational functioning. And it has to represent a significant decline from a previous level of functioning. And Alzheimer's disease is the most common cause of dementia. Probably about 60% of all types of dementia, of all dementias are caused by Alzheimer's disease. And Alzheimer's disease has a fairly typical pattern. Now there are some atypical presentations of Alzheimer's disease, but most Alzheimer's disease have an insidious onset, which we consider as it means it's very subtle. At the beginning, people usually say, I just thought that this was normal aging. My loved one, my wife, my husband, they were losing things around the apartment. They were repeating the same stories over and over again. They were having some difficulty finding the right words, but I didn't think too much of it because they were still functioning okay. That's usually how Alzheimer's disease progresses. And then it's a very gradual progression where eventually it starts affecting daily functioning. And it's associated with very specific changes in the brain, what we call senile plaques or amyloid plaques. That's essentially these proteins that clump together between the nerve cells in the brain and have some toxic reactions. We'll talk a bit about that afterwards. And it's a progressive condition. So, unfortunately, from the time of the onset of symptoms, the average lifespan from Alzheimer's disease is between 7 and 10 years. So initially the symptoms are very mild, but if there isn't another illness that someone suffers from, which ends their life, the dementia itself, the Alzheimer's disease itself, will lead to the end of their life. And the Alzheimer's Society on their website has a number of warning signs that they list. And as I mentioned, that memory loss, repeating things or losing things around the house, asking the same questions or asking the same stories, that's the most common early symptom of Alzheimer's disease. And the risk factors for the development of Alzheimer's disease include, obviously, older age. Women seem to be at a bit higher risk than men for developing Alzheimer's disease. And it's not just because women live longer. There seems to be some other factor as well that makes women at greater risk for developing Alzheimer's disease. Genetics play a role too. So Stacey talked about early onset Alzheimer's disease or young onset Alzheimer's disease. So we know that there are 3 genes that if someone has them, that is going to cause people to get Alzheimer's disease, typically at an early age. It can be very young, even as young as 30 years old. Now, for most of the late onset Alzheimer's disease, most Alzheimer's disease occurs in people after the age of 60. There is another gene that puts people at slightly higher risk of getting Alzheimer's disease. So, but genetics probably altogether only plays a role accounts for about 40% of disease, right? So the environment and things that we potentially could have some control over maybe plays a role in about 60% of the disease. So we have to think about what can we do to modify the way that we live and the way that our environments are that could potentially prevent us from getting these illnesses. Head injury, lots written in the newspapers these days about, hockey players and boxers and the risk of getting dementia, but Alzheimer's disease too. Head injuries are a risk factor for that. Inactivity, so that's really someone with a completely sedentary lifestyle, like basically sitting on the couch all day would be a risk factor. Even a mild level of activity would reduce your risk for developing Alzheimer's disease. And then the things that we think of as causing, risks for heart attacks or strokes are also risk factors for Alzheimer's disease, like high blood pressure and high cholesterol and smoking. All the studies show that low education is a risk factor. The idea behind that is that if you're highly educated, probably what happens is that you have a greater cognitive reserve. So for the same amount of pathology or disease that's in the brain, you're more likely to be able to compensate for that because you have different strategies for solving complex problems, right? Or other areas of the brain that aren't affected by the disease might be able to make up for the areas that are affected. So that's why we think education probably is a risk factor for the disease. If you have mild cognitive impairment, that's a risk factor. And actually interesting, which is obviously very meaningful to me as working in geriatric psychiatry, is depression itself is a risk factor. And that might be a modifiable risk factor. If we catch depression early enough and treat it early enough, we might be able to reduce the risk of people getting Alzheimer's disease, because depression itself does cause changes in the brain that have some similarities to some of the changes that take place in Alzheimer's disease. So everyone always is interested, well, what can I do to try to prevent myself from getting Alzheimer's or a loved one from getting Alzheimer's? So there isn't a ton in the literature that we know about to prevent it. And these aren't studies that say, well, if you do this, it's going to reduce the risk by this much. These are, long-term studies where they just look at all the things that people are doing in their life, and they say, well, the people in this group seem to be less likely to get Alzheimer's disease than the people in this group. And it seems to be the people that exercise more are less likely to get the disease than people that don't exercise at all. And it's actually interesting. The Alzheimer's Society put out this big paper, it was a couple of years ago, called The Rising Tide. It was talking about major demographic shift in Canada and the huge economic burden, the social burden that dementia is going to cause. And one of the recommendations they had is if we had a public health intervention where we got people to exercise more, we could probably reduce the number of people that are getting Alzheimer's disease. Cognitive engagement and socialization is probably helpful as well. So I know you watch TV, I think what's that program, like the ads for Luminosity, or these games, the cognitive stimulation games that you can get on the internet. The idea is that it might protect you from getting dementia. Now, unfortunately, there's not a lot of evidence that there's any specific kind of cognitive stimulation game that's going to protect someone from getting Alzheimer's disease or another dementia. But it probably just remaining, keeping your brain active, and especially social settings, seems to have some protective effect. So, going to study groups or book clubs or playing bridge or cards, that seems to be helpful. Mediterranean diet. So put up your hands if you know what the Mediterranean diet is. Okay, well, about half the audience, okay? So, as I entered this field, I was reading, what should I do? I actually tried to go on this Mediterranean diet. Didn't work very well for me. Didn't agree with my system. But what the Mediterranean diet is, essentially, it's low saturated fats, low red meat, and a lot of fresh fruits and vegetables and nuts and olive oil, like no processed foods. And interestingly, too, it usually includes a little bit of wine, which isn't too bad. So there's many studies, and no doctor is going to recommend this, and I'm not recommending this today too, but there are many correlational studies that show that people that drink a moderate amount of wine are at less risk of developing Alzheimer's disease and other kinds of dementia. Now, we don't know certainly. It's kind of like a U-shaped curve. So if you don't drink at all, you're at higher risk. And if you drink too much, you're at higher risk. But if you drink just the right amount, right? And it's actually more than you might expect, So it's about one to two glasses of red wine a day. Probably one to be on the safe side. But again, because there's so many other illnesses that are associated with alcohol use, so many mental illnesses that are associated with alcohol use, so many physical illnesses like cancer, we don't recommend it. But the studies do seem to indicate that if you drink a small amount every day, you'll have a little bit of protection. So what causes it? I talked about these amyloid plaques. So the most consistent finding in the research is that there are these proteins that naturally occur in the brain. They're called beta amyloid. And typically, there's this protein called amyloid precursor protein, and it gets broken down either to A-beta or beta amyloid, or it gets broken down to another protein, and that other protein is generally soluble. It means it can be dissolved and it can leave the brain. But if you make too much of this A-beta, it clumps together, and it's insoluble. Like there's no way for it to get out of the brain. It tends to stay in the brain, and it has toxic reactions. It can get in between the cells so that the cells can't talk to each other anymore. It seems to cause cell death in some cases. It causes changes within the cells, what we call hyperphosphorylated tau. Might be related to that. So that is the biggest theory of how Alzheimer's disease takes place. That's what we think causes the pathology of the illness. We don't know this for sure. And there's been some research more recently because some of the drugs that we've been trying haven't worked out as we had hoped. That makes us question it, but this seems to be the case. And there's some reasons I wanted to share to you because I thought might be interesting is that more recently, last year, they did this really interesting study that was published in the New England Journal of Medicine where they looked at people with the young onset Alzheimer's, where it's much easier to predict who's going to get the illness because you can get that gene that you know that someone's going to get Alzheimer's disease. And they looked at changes in the brain and in the blood much earlier than they would expect them to get the disease. And they found that as early as 25 years before they get the disease, they could see changes in the brain or in the blood or in this really the cerebrospinal fluid, which you can find through looking at the lumbar puncture. And the important thing here is that a lot of research has been done in the last 10 years looking at investigational drugs to try to change the disease process itself or try to stop the disease in its track or reverse the disease. And most of it's been around trying to get rid of this A-beta, either stop the A-beta from being produced or find ways to block make the A-beta soluble to get it out of the brain or clear the brain or prevent it from being formed. And unfortunately, these trials have not been successful. So I think the next question is, have they not been successful because we haven't been using them early enough? Maybe when you have too much A-beta, these amyloid plaques in the brain already, it's too late. Maybe you need to try these drugs very early on, and I think that's one of the exciting things in the field is that we're starting to develop markers to predict who's going to get the illness 10 or 20 years before they actually get the illness, and maybe that's the time to intervene. I want to talk a little bit about the progression of Alzheimer's dementia because it will help frame the discussion for what we do in our inpatient unit. So, dementia starts at stage 4 here, and that's the decreased ability to perform complex tasks. And that typically lasts about 2 years. It's different in everyone. And then in stage 5, which is moderate dementia, people will require some assistance in choosing the proper clothing. And then stage 6, which is moderately severe dementia, people start to require assistance with almost all of their day-to-day activities, like dressing, bathing, toileting, and becoming incontinent towards the later stage of that illness. And then the last stage, which is the severe dementia, and it can last, in some cases, quite long, for up to 6 years, people gradually lose the ability to talk, walk, and sit up. And the kind of patients that I'm going to be talking about today are the patients that are in stage 6 or stage 7, where verbal communication is becoming extraordinarily limited, and physical functioning is deteriorating rapidly, and it becomes a much greater challenge in how to engage these individuals. If you think about it, one of the ways that we look at Alzheimer's disease is kind of a reverse of how we develop, right? So if you think about what skills you got as you grew up, you tend to lose them in the same order, and that in stage 6 or stage 7, you're looking at a mental age of someone who's under 2 years old or under 1 year old, and you can imagine, I mean, I have a 2-year-old at home. The challenge is you have a grown individual who's physically strong. The challenge is in trying to provide care for that individual and finding ways to engage them, and I think that's the challenge for us that are involved in this field. So there's other common types of dementia. Vascular dementia is dementia caused by strokes or caused by disease of the blood vessels in the brain. That probably represents 20% of dementias. Dementia with Lewy bodies represents about 10% of dementias. That typically presents with visual hallucinations and a lot of fluctuation in some Parkinson's symptoms. And Parkinson's disease dementia is very similar to dementia with Lewy bodies. Frontotemporal dementia is I think Stacey had mentioned, tends to be an early onset dementia. So people typically get it between the ages of 40 and 60. And rather than having memory problems early on in this illness, it produces profound behavioral changes. So typically things like being completely apathetic and losing interest in everything, losing the interest in hygiene or looking after the basic care needs of yourself, disinhibition or saying things and doing things that would be completely socially inappropriate and upsetting. And then I mentioned if you drink too much too, you can get alcohol-induced persisting dementia. I just show this slide to show that it's a major problem in our society right now. But in 2008, there were about 425,000 people with dementia in Canada. In 2038, the projection is about 1.2 million. So we really have to think about how can we best care for and provide a meaningful quality of life for individuals with dementia and their caregivers. And this slide shows that now there are more people living in long-term care facilities than in the community or in their own homes for people with dementia. In 2038, the projection is that it's going to reverse. More people will be in nursing homes. More people will be living in the community. They won't be in nursing homes. Which, again, I think it speaks to how important it is that we have people like Arlene involved in the kind of research that she is, because institutional care is going to be less and less available to people. We have to have creative ways to care for people with dementia. at home. So now I'm going to talk about our inpatient unit and what we can do for people with behavioral and psychological symptoms of dementia. So I'll give you two examples of people that have recently been in our inpatient unit. So one is an 85-year-old woman from home that has dementia with Lewy bodies in the severe stage of her illness, who in the last 4 months has had a very rapid deterioration in her functioning to the point that she wasn't walking anymore. She needed someone to feed her. She was talking minimally. She was losing significant amounts of weight. And most distressing, she was living with her daughter and her husband, is that she was crying about 7 hours a day. And she'd been on multiple different treatments to try to stop the crying. Nothing was working. And then another example is a 62-year-old woman from a nursing home, and most of the patients that we have in our unit do come from nursing homes, with early onset Alzheimer's who appeared frightened all of the time or most of the time and pacing continuously throughout the unit and just suddenly hitting people throughout the day. So this is supposed to frame the kind of work that we do and what we can do to try to improve the quality of life for individuals with a severe stage of dementia that have significant behavioral disturbance. And unfortunately, these types of scenarios, even though they're extreme scenarios, the types of problems they're presenting with are unfortunately not that uncommon. And this slide shows you is that even though we think of Alzheimer's and other dementias as being memory illnesses or cognitive illnesses, they're really neuropsychiatric illnesses. So what that means is they present with a lot of psychiatric complications like hallucinations, right? That's seeing things or hearing things that aren't there. That occurs in up to 30% of people with dementia. Or false beliefs or paranoia. Again, 30% of people. Misidentification syndromes. That can be like thinking that your wife isn't really your wife. And, I've seen that many times where it's very distressing for a caregiver to be caring for someone they love and they're saying, where's my wife? You're an imposter. And that occurs in 20%. Depression occurs in up to 25%. Anxiety, 50%. And you can see down the list, and aggression, unfortunately, is in up to 40%. So we need to be mindful. Most of the research that's done on dementia, their outcome measures look at things like memory and cognition or functioning. But these behavioral and psychological symptoms are actually what's more correlated with distress in the individual and distress in caregivers. So this slide shows you what the impact is of these symptoms. These symptoms are what's more correlated with patient and caregiver distress. It's not the stage of the illness or the level of functioning or the cognitive decline. It's the degree to which they have behavioral and psychological symptoms of dementia that determines the amount of caregiver distress or patient distress. And obviously there's increased risk of patient and caregiver injury when someone's aggressive. It's associated very highly with placement in a long-term care facility. People with more behavioral and psychological symptoms have a more rapid course of the illness. There's an increased risk of mortality, and there's a huge economic cost as well. So the question is, what can we do to help? So I'm going to describe our inpatient unit now. So we have a 23-bed inpatient unit at Ontario Shores called the Geriatric Dementia Unit, and it's for patients that are in the late stages of the illness, moderate to severe dementia. So typically, their ability to verbally communicate is very limited at this stage, and they typically require full assistance in most of their activities of daily living. And the main principle in dementia care is try not to take people out of their own environment, right? If you can care for someone in their home or where they live, that's the best. Because you can imagine if you don't have memory and you're just used to routine and structure and familiarity, to all of a sudden be taken out of your environment and put somewhere completely new with new people, new noises, new caregivers, that is not going to be good for you. And then to have to go back to your old environment, it's a nightmare. We try to avoid it at all costs, right? So the only time anyone should be hospitalized, in my mind, with significant psychological or behavioral symptoms requiring hospitalization was when there's an acute safety issue. Other people are significantly at risk, or the individual is significantly at risk of significant harm, like in that second case I described, or there's significant treatment failure. You've tried so many treatments in the community and nothing's working, and you want to improve the quality of this person's life, like in the first case, the woman that's crying all the time. And the important thing is that we use multi-component assessment and interventions, and I'll talk about that. So the interprofessional team is key. It includes geriatric psychiatrist, general practitioner, clinical nurse educator, obviously many nurses, many with subspecialty certificates in geriatric and mental health nursing. social workers that do a lot of work with families and with the community agencies that are involved in our patients' cares. Neuropsychologists, they do more specialized cognitive assessment to determine the relative strengths and weaknesses of the individual, as well as help clarify diagnosis at times. Recreational therapist is very key in helping us find ways to engage individuals. I'll talk a little bit more about the psychological theories around why people have behavioral disturbance and dementia, but the recreational therapist is obviously very key in helping us solve some of these issues. Occupational therapist helps with mobility and level of functioning. Physiotherapist to help reduce falls and improve mobility. Dietitian, personal support workers, and we have students from all disciplines as well. So the question is, why do people with dementia have these behavioral and psychological symptoms? So some people say is that, there's obviously major changes that take place in the brain. Maybe it's just the changes that take place in the brain that cause these symptoms. But there are some psychological theories as well. So one is this idea of a lowered stress threshold, is that, for most of us, we can tolerate a great deal of stress without becoming aggressive or agitated because we have a much greater cognitive reserve. But the idea is that people with dementia, because they have so much damage to their brain, it requires a much lower amount of stress to produce the kind of agitation and aggression which for us would need to be really out of the ordinary, not something that you would experience most of the time. Learning theory posits that some of these behavioral and psychological symptoms are differentially reinforced because typically individuals, when they're calm, they don't get as much reinforcement or social interaction from others. It's only when individuals are distressed or agitated or aggressive that they get attention from others. So if we think about classical or operant conditioning, is in somehow we're differentially reinforcing the problematic behaviors, and that's why we're seeing them occur more often. And probably the most common theory is the unmet needs theory, is that for someone that is unable to communicate effectively verbally, it's very difficult to have their needs met. And you can think of as a behavior or psychological symptom as a type of a communication. So that people experience these distressing symptoms or become agitated or aggressive or paced because a basic need of theirs is not being met. And it's our job to try to figure out what that basic need is. So I think the most important thing to remember is that consider these behaviors or symptoms as a way of communicating and try to figure out what the individual is trying to communicate to you. And you can imagine that's very challenging. So when anyone's admitted, we do a very comprehensive interprofessional assessment, which includes a diagnostic assessment. We look at the cognitive strengths and weaknesses of the individual. Very important to know what someone's strengths are, not just their weaknesses, because oftentimes, I think Arlene spoke very well to this, oftentimes we make assumptions that people can't do things. And you can find that someone might have a relative strength in a certain area that you can tap into and can be very helpful in treatment planning. Personality and personal psychology is very important. Previous life experiences have a huge role, even though people's personality changes a great deal when they have a dementing illness. There are aspects of their earlier personality that influence the way that they behave in the illness. We pay very close attention to physical health, and we look for signs and symptoms of delirium. We do very close pain assessments. Pain is often a cause of behavioral disturbance and dementia, unfortunately. For someone that can't verbalize that they have pain, you have to look for other cues that someone might be in pain, like their facial expressions or the way they respond to other people touching them. Sensory deficits are important. We look for depression or psychosis, which is a loss of touch with reality, like hallucinations or delusions. Environmental factors. It could be too noisy. It could be boring, the environment, or understimulating. The environment could be set up in such a way that it's not meeting the patient's needs in an optimal way. And unfortunately, there's not always that much control you have over environmental factors. Social factors, recreational factors, and family. Family is an extremely important part of what we do. So when anyone is admitted to our units, one of the first things we do is we sit down with family, with our team, and we gather information, but we also provide education about the stage of the illness that their loved one's at. and we have a very realistic and open conversation about what the course of the illness is going to look like. I want to. I think the challenge one of the biggest challenges in dementia care is it's very important to remain hopeful and optimistic. But you also have to remember that this is a degenerative condition. So longevity of life may not be the best healthcare goal in this illness, especially at the later stages of the illness. Quality of life, in my mind, is often the better goal for most people. And a lot of the work that we do with families is to help them grieve for what they've lost with the person that they love so much, and help them also see how we can do things to improve the quality of life for their loved ones so that they can have a meaningful and valuable life even though they have this very difficult illness. We use structured assessment tools as well. It really speaks to the importance of being able to understand behaviors when someone can't tell you what's going on. So I just have an example. It's hard to see. This is a dementia observation system. What you can do is, I know the nurses are laughing here because they call me Dr. Doss all the time, because this is short form, this dementia observation system. But the idea is that you can track behaviors on a half-hour increments and look to see what an individual is doing throughout the course of the day. And you look to see what happened immediately before the behavior and what happened after the behavior. The idea is that by doing this, you can start to understand the behavior better. What is driving the behavior? For example, is someone only aggressive at mealtime when they're sitting next to Mr. X? Maybe there's something about Mr. X sitting next to them that's making them aggressive. It's very hard to capture that when you have, different nurses or PSWs working every day, different team members coming in and out. This allows a systematic way of trying to understand the behavior and changing your care plan. Very important to create individualized care plans, looking specifically at what is the best way to communicate with this individual, what is the best way to support them in mealtime, dressing, bathing, and recreational activities, and particularly addressing anything that seems to be driving the problematic behaviors, what we call the triggers for the problematic behaviors. There is some evidence around activities and programming that's helpful for individuals with behavioral and psychological symptoms of dementia. So this is a picture of a snoozle-in room. So how many people have seen a snoozle-in room before, know what that is? Again, it's about half. So one of the theories around this unmet needs hypothesis is that when you or I are over understimulated, we can actually do something about it. Like when we're bored, we can get up and do something that interests us. If we're overwhelmed, we can get up and leave that environment. Someone that can no longer communicate or walk effectively and is in a locked environment can't do that. And the idea is that maybe a lot of agitation or aggression is caused by a mismatch between what an individual needs in terms of stimulation and what the environment is providing. A snoozle-in room is a multi-sensory stimulation environment that an individual with dementia can go in with a therapist and explore at their leisure. And you start with very basic and simple things, but it touches on all the sensory modalities like sight and touch and taste, and you can see what attracts the individual so that they can find that optimal level of stimulation. And there is evidence that while the individual is in the snoozle-in room, levels of agitation go down and levels of relaxation improve. Now, unfortunately, the studies show it doesn't seem to last longer outside of that snoozle-in room, but again, it speaks to that there is something to this theory, right? If we can find a better match between what we're giving people throughout the course of the day, we can probably do a lot to reduce these types of behaviors and symptoms. Exercise is helpful. Music therapy. In terms of music therapy, individualized music therapy that has personal meaning to the patient is going to be more important than just general playing songs and music. Montessori-based activities, which is really taking activities at a very simple, basic element and using things like repetition and going from the simple to the complex to help people perform valuable or meaningful activities. Cognitive stimulation and validation. The idea behind validation is that, at certain stages of the illness, being oriented to reality isn't as important. What's important is that you have meaningful experiences with people. And I think it's often hard for those of us that work in the field and those of us that are caring for someone that we love to try to experience the world from the individual with dementia's eyes. And that's what I see as validation therapy is all about, is trying to experience the world from the individual with dementia's eyes and validating their experience as much as possible as it's their reality. And there is evidence that altogether these types of therapies improve mood, they reduce problematic behaviors, they reduce caregiver stress, they delay nursing home placement, and those interventions that have multiple components to them seem to have the best evidence. They work the best. But overall, I think the speakers that have spoken today have all emphasized engagement is the key, right? If you can find a way to engage an individual, I think that you'll do a lot to reduce these types of symptoms, whether it's through technology, whether it's socially. The challenge is, and I was talking to Arlene just before she left, is that I think I read somewhere in long-term care facilities in Ontario, we pay for about 15 minutes of nursing care a day per individual and less than 2 hours of PSW care per day per individual. So for someone that can no longer talk effectively or move effectively, that means most of their day is spent on their own and unstimulated. So how do we engage someone in a meaningful way when we don't have a person to do that with them? So there's some examples here, lifelike dolls. So if you think that people at this stage of the illness have a mental age of 1 or 2 years or less, oftentimes the lifelike doll will feel like a real baby, and it can give people a great sense of meaning and purpose. And it's sometimes difficult for families to understand because it feels infantilizing at the beginning, but we've seen some very touching and warm and fantastic results from this type of thing. Picture album, sorting socks, the picture with that it's a stuffed dog. It's actually from a research study where they're looking at creating like a technological dog, right? A dog that can interact with the individual with dementia, so that provides some feedback as well. And that's why I'm so interested in what Arlene's doing, because human resources are obviously finite. But with technology now, we can hopefully provide meaningful ways of interacting with people that don't require us to have someone with someone 24 hours. The shaver is kind of interesting because it's to remind us that we need to be creative in thinking how to engage someone. And I remember a patient on our unit, his biggest challenge is he was living in a nursing home, and he was pushing wheelchairs and kind of throwing them down the hall, and they were hitting other people like a bowling ball. It was very distressing, and that's not usually the kind of thing that medication is going to help for too much. And we tried creative ways of occupying him during the day, so he didn't do that. We tried giving him a walker or canes or things to play with in his hands, and nothing was working. But one thing we noticed is that he could still use an electric shaver, and he seemed to like doing it. We took the blade out, and whenever we noticed he was getting a bit more restless, we gave him this electric shaver, and he could spend 3 or 4 hours walking around with this electric shaver. And when he calmed down, he stopped. He would give the shaver back, or we'd take the shaver away, and we'd give it back when he's becoming restless again. And the pushing the wheelchair stopped with that. So the key is engagement. How can you engage an individual? Medications do play a role, too. Unfortunately, not enough of a role. The evidence is not great. Typically, when people come to our unit, it's because other treatments have not been successful, so we do use medications always. So cognitive enhancers are medications that are really designed to help preserve memory or cognition and functioning. There is some evidence that these medications do help to prevent the onset of new behavioral problems. Unfortunately, there's not a ton of evidence to suggest that they treat behavioral problems that are already there. That being said, we do still use them because there are some other benefits in people with dementia. And the two main classes are the cholinesterase inhibitors. Those are medications that increase acetylcholine in the brain. That's a chemical that's very good for memory. and it's depleted in people with Alzheimer's and other kind of dementia. And the other one is memantine, which is an NMDA receptor antagonist. So glutamate is a chemical in the brain that excites the nerves. The idea, if you excite a nerve too much, that's the brain cells, you can cause toxic reactions. You can cause cell death. So by blocking those cells, by blocking those receptors that the chemical would bind to, you're less likely to cause cell death, and that seems to be helpful. And then there are some specific medications that can be used for these behavioral and psychological symptoms. So antipsychotics, which were medications originally used for the treatment of schizophrenia, have the best evidence at reducing agitation and aggression. We don't know why. The results are not hugely robust, but they do work in a number of people, and we've had very good success using this class of medication. But there's problems with the medication as well. Is there is a slightly increased risk of stroke-like events and a slightly increased risk of death from all causes when you use these medications. So if you ever look it up, you'll see there's a black box warning about using these medications in people with dementia. That being said, they're the best studied class of medications, and they work the best. Antidepressants, there are some studies that show even antidepressants have some effect at reducing agitation and aggression in people with dementia. They aren't as robust as the antipsychotic literature, and they're also associated with certain risks and side effects, but we do use them in anticonvulsants. You know, one of the messages I want to give, too, is that in the kind of care we provide is we don't give up. So just because there isn't, we go through the evidence-based treatments first, but where the evidence doesn't exist, we try something else because we don't think that people should be suffering when there's potentially something else that we could be doing. I'll just give you an update on the two patients. So the 85-year-old woman that had come from home and was crying all the time, you know, we tried numerous antidepressants and nothing was working. We ended up using something called electroconvulsive therapy, which is probably the most effective treatment we have in psychiatry, modern psychiatry, for depression. It works in about 60 to 80% of people with depression. It's very hard to diagnose depression in someone with severe dementia because it's severe dementia, you lose weight and you become apathetic. It's just a natural course of the illness. But because she was crying so much, we thought she might be depressed. And with ECT, she stopped crying. And she's back at home, and she comes here once a month to get maintenance ECT treatment. Her dementia is still at the severe stage, but her quality of life is tremendously improved, and her family is very grateful for it. And the 62-year-old woman from the nursing home that's frightened all the time, we were able to use multiple different antipsychotics, and eventually we found one that reduced her level of paranoia and anxiety, and she was able to go back to the nursing home. We see research as also being a very important part of the work that we do here because there is limited evidence still about how to treat these symptoms. So one research study we're doing right now, and I see Dr. Alakil is here, who's a clinical and research fellow here, who's very much involved in this research study, looking at the safety and efficacy of electroconvulsive therapy for the treatment of the behavioral and psychological symptoms of dementia. There is some research out of Harvard where they looked retrospectively at people they used this treatment for that's been helpful, and we're doing a prospective study, which means that we're following people from before we give them the treatment and seeing how they respond to the treatment, and hopefully we'll be able to have some publications soon to show our results. And one of my colleagues, Dr. Waxman, is studying the education's impact on healthy seniors' attitudes and healthcare preferences regarding the different stages of Alzheimer's disease. So important is being able to have discussions about how you want advanced care planning to be done for yourself. So just some take-home points, and I'm happy to answer any questions. You know, the behavioral and psychological symptoms of dementia are extremely common. They're extremely common in dementia. To effectively treat these symptoms, you need a very effective and a very creative interprofessional team. You know, and although medications can be part of the answer, they're certainly not the only answer, and you need to have a very systematic approach of evaluating the symptoms and, you know, a committed team, committed families at implementing them. So thank you, and I'm happy to take any questions.
We have a few minutes for questions, if anybody would like to pose any questions to Dr. Fischler.
I have a question regarding the assessment tool that you have posted up, and I was just wondering how
So to repeat the question was, how often do we use the neuropsychiatric inventory in our practice? So it's a great question. We typically use it when we want to evaluate the effectiveness of a specific treatment. So we don't typically use it when someone's first admitted to the unit, but say we want to use an experimental treatment like electroconvulsive therapy for the treatment of aggression in dementia would be considered an experimental treatment. We're studying it. There's a little bit of research out there, but certainly it's not robust enough. So we want to be able to very systematically evaluate, is this working or not, with numbers. So we would typically do this before we fill out the inventory with our nursing staff before we start the treatment. We do it at intervals over the course of the treatment so that we can see if people are responding, and we use it as a guide for when we should stop the treatments as well. And that's one of the tools we're using in our ECT study. And just for people that don't know, the neuropsychiatric inventory is used in a lot of research studies in dementia. It looks at all the different kinds of behavioral and psychological symptoms that I described, things like the delusions, hallucinations, agitation, aggression, eating problems, sleeping problems. And it allows you to quantify how often they're occurring and how severe the behaviors are and come up with a number at the end of the day. So it's a more objective way of evaluating outcomes. Yes.
You spoke about this genetic marker where you can have a really high probability of predicting a person who's going to develop Alzheimer's. So there's lots of people walking around out there that could find that out. Is that better for them to just be blind about it, or would it be better for a person to know?
I mean, so the question is there are some genes that we know that we know if people have it that they're going to get early onset Alzheimer's, and the question is, should people know that, or is it better to be blind about it? It's a very difficult question. There's this big controversy now with whole genome scanning is becoming relatively less expensive. Like, you can get your whole genome scanned probably in the States for about $3,000. You could know everything that we don't know exactly what you're going to get, but the question is do you want to know what you're at risk of? Is it going to change your behavior in your life? Is the information going to be used for malevolent purposes, like are insurance companies going to decline coverage if they know you're at risk? What we do in Canada, if I have a patient that has early onset Alzheimer's, is I'll speak to the families and offer genetic testing. I don't do it myself. I make a referral to a geneticist. Offer a referral to a geneticist to speak to the family about the risks and benefits. The main benefit is around family planning. But the risk is, there are risks too. Some people don't want to know that information. Now, there are genes. So there's 3 genes that if you have it, you will get Alzheimer's at some stage. There's another gene that just increases your risk, and that we don't offer to anyone, because if you live long enough, dementia isn't a part of normal aging, but if you live long enough, a lot of people do get dementia. Like, after the age of 85, a third of people are going to have Alzheimer's or another kind of dementia. So to know that you have a gene that puts you at higher risk is probably not all that meaningful, and just going to cause distress.
I think we should probably stop there, just in the interest of time. But I want to thank Dr. Fischler with his own gold bar-filled bag.
Thank you. Wow.
That's perfect. Yeah. Well, fantastic. Okay, that was wonderful. Thank you so much. Our final speaker today is really somebody that I think is going to help put a bit of a finer point on the issues of system navigation. In other words, how to get services, access services, those kinds of things in Durham and around here. And that is going to be our own Sheryl Bernard. Sheryl Bernard is a nurse. She's also a PhD student at this point. She is the director of the geriatrics and neuropsychiatry program here. She's very involved in this region in a whole range of important initiatives, including being an active participant on the expert panel for the Regional Specialized Geriatric Advisory Board or Committee, I'm not sure. She's been part of the design team for Behaviour Supports Ontario, part of the steering committee for Regional Specialized Geriatric Services, and a range of other important engagements, including very frequently with the RNAO, I believe. Anyways, she's also an adjunct professor at UOIT. She is one of our most valued clinical and administrative folks here, and it's a pleasure to have her speak to you. Sheryl.
Good evening, everyone. For anyone who knows me, I like to keep things interactive, get everyone moving. I'm an old aerobics instructor, so I can't help it. So first of all, can I just see the hands of either care providers, anywhere along the continuum of dementia care? So whether you're a geriatric psychiatrist or whether you are a mental health outreach nurse, a PRC, or anywhere along the continuum at the system level. So can I just see the individuals in the room who... Quite a number, so more than 50%. So I'm going to give you all the opportunity to walk the talk. So all these various tables that Dr. Klassen mentioned that I sit at, we've done a lot of talk around system navigation, creating a seamless care for dementia care, creating integrated services. So what I want you to do with this interactive exercise, and really it won't take long, I'm going to ask Dr. Phil Klassen to keep time for me. I'm going to give us 5 minutes. And what I want you to do is to come together, have a conversation amongst yourselves, share what you do along this continuum of dementia care, and establish a circle of care amongst yourselves. I'm going to ask if I can see a show of hands of if there are any care providers for a person with dementia. Okay, family members. Okay, so I'm going to ask probably 2 people to act as the family or care providers, and I want the individuals just to come forward. Just come forward, actually, and I'll give you the instructions as we go along. No one will be embarrassed. There's strength in numbers. Come on down, people. Let's walk the talk here. I want people who work in dementia care anywhere along the continuum, whether it's a memory clinic where you're going to be doing the diagnosis of dementia, come on down to the front. Whether you work in right along all of the sectors, actually. I want cross-sectorial representation standing here. I was going to say something, but I won't. Uh-oh, John, what happened to am I supposed to, I'm sorry, I used the wrong,
We'll look after it. You can manage he'll help you with it.
Okay, I want to go to a particular slide, though.
Okay.
Oh, that's still
It's Alon's talk.
Okay.
Yeah.
Can you bring me to this slide, and then I'll go to that slide. All right. There's a few more up there. But are you, okay, so if you're all frontline nurses, for example, we can have 1 or 2 to represent the frontline. No, stay together, everybody here. Okay, so if you guys can just walk forward, thank you, John, forward a little bit, just away from the slide so that people can see the slide. So oftentimes the conversations that we have, basically this is a pretty common picture that we come up with in terms of the system, and either the patient or the family is in the center. So I think that conceptually, the majority of us agree that the family or the patient is in the center, and this is basically what we get from the family or the caregivers or the patient themselves, what the system looks like. So I'm very, very passionate about system navigation and trying to establish the seamless care for anyone with dementia. So what I want you all to do actually is just have some conversation amongst yourselves as care providers and come up with a circle and try to see if you can create this seamless system for care amongst yourselves. So you need to talk to each other about what it is that you do, what type of care you provide, at what point, whether it be before the dementia is even diagnosed, right up to perhaps stage 6 or 7, with which Dr. Fischler explained to us. So you have 3 minutes in which to have a conversation and establish a seamless circle of care. Do 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 do.
Can I get 2 observers, please? Just to observe what's happening here. Thank you. My presentation won't take long because everybody's already spoken to it. What? Oh, gosh. When you go last, you recognize that a lot of the things have already been said, so you don't repeat it. Phil, could you let them know they have 2 minutes?
So
Or 1 minute.
Natural categories here of how you would
No,
organize yourself.
no, one person has the mic.
Natural.
You have 1 minute. I'm going to give you the opportunity to truly create a circle.
Or caregivers. So who's our caregivers? We don't have them yet. Okay. We're going to be at the beginning. Okay. You should be in the middle.
I guess you should be in the middle. I was thinking too.
We're at the end.
I'm just an observer, so you can.
Oh, okay.
Okay, well now we are.
So then all of you So, but you support people from the community and from long-term care. So maybe
We're weird. Because we're like, yeah.
Are you end stage?
No, I would say we're more. But more than.
All right, are we ready? So we have a family member here who just wants to have a better understanding of where and how and what type of care will be provided for a loved one. So where do we start? We need the mic out.
Sheryl, yeah, I was going to say, they may not be able to hear you on the webcast unless you're using
Okay,
the mic.
so there's a mic. And then I want you to hand the mic around, starting from the beginning, from diagnosis, right around to this wonderful circle of care and continue of care that you've all provided. And you must speak in the mic, please.
Hi, I'm Michelle Pepin. I'm the Director of Family Support at the Alzheimer's Society. So oftentimes we are the beginning point for families to, when they're even just first noticing symptoms of the disease, to come through our door and just sort of seek information and guidance around what the next step is in terms of support and service. And we also support families through the continuum of the disease. So we could be beginning, middle, and end, but I put myself at the beginning. So that's sort of the nature of what we do at the Alzheimer's Society, so helping families navigate the system and the community through the continuum of the journey with the disease.
Thank you.
We're located in the community in Durham, so we're located at the Oshawa Shopping Center in the Executive Center.
Hi, I'm Debbie Mitchell. I'm a community nurse clinician. So you may contact our services, which is the Integrated Psychogeriatric Outreach Program. If your loved one is exhibiting symptoms and you're not quite sure or you haven't received a diagnosis yet, I can come in the home, do a comprehensive assessment, perhaps provide some strategies as to how better manage the behaviors that you're seeing or the issues that you're having, and link you to services like the Alzheimer's Society, or have you seen by a geriatric psychiatrist or a geriatrician. And we do some short-term follow-up, and of course we're always there for psychological support, but not on a long-term basis. Next. I'm sorry, we actually have a partnership between Ontario Shores and the municipality of York Region, and our program is called IPOP. IPOP, Integrated Psychogeriatric Outreach Program, and that's based out of the Newmarket Health Centre. But I'm an employee of Ontario Shores. It's one of their regional partnerships.
Hi, my name is Susan Sheryl. I'm a registered practical nurse with BHA Health Services, and I would be the person that would come into your home to provide in-home nursing care if that is required, and hopefully to provide you with information regarding all these wonderful services if you need them. BHA Health Services provided through the Community Access Center and paid for by the government if nursing is required.
Thank you.
Hi, my name is Lada Al-Majidi. I'm an occupational therapist. I work with BHA as well. Yeah, and I provide the service in homes, in the community, and also I work in a few nursing homes. Main thing that we do in the start actually to evaluate the functional levels, and if there's any deficiency, we assist them by providing any kind of supplies, especially for mobility, for feeding, if they need any assistive devices, so we provide that. And during the process in this journey, you always will need an OT to evaluate and reevaluate the functional levels until they go to nursing home. And so.
Hi, I'm Leonard Rose. I'm a geriatric mental health outreach nurse. I do exactly what you do, but we divided the line right here because this is the point when now the person is in a long-term care home. So they're no longer in their own residence, wherever that is, but now they're in long-term care, and they're needing the same type of assessments and assistance with behaviors, with dementia and Alzheimer's. I'm with the Central East Lynn, and I do the Scarborough hospitals, as well as there's two members back there with the Scarborough hospital team. I'm based out of Rouge Valley Centenary. They're out of the Scarborough Hospital at the Grace site. And that's what I do. So I provide the frontliners and also the staff and also the GPs in the home with some assistance around the mental health, and I work with two psychiatrists.
Hi, my name is Ron Rainian. I'm the PRC, or Psychogeriatric Resource Consultant, working here in Ontario Shores. My jurisdictions or catchment area is within the Central East Lynn, but within specifically within the Durham region. So I do cover about 11 long-term care homes out of the 19. So presuming that your dad is already in the long-term care, that it's within my coverage. So my role within the system is that I would go in if your dad is exhibiting behavioral symptoms of dementia, I would go in and offer support and education to the staff, the nurses, frontline caregivers, and assess the needs that is identified from that behavior, so identified from the symptomology of that behavior. And I also do capacity building, staff education, helping the Central East Lynn with the BSO, and in case your dad has to go to a tertiary hospital, specifically in Ontario Shores, I could also help navigate that system, connect with our inpatient team, what's going on with your dad, and transfer that to Ontario Shores. And at the same time, when your dad is ready to go back to the long-term care where he came from, I could go in as well and have that transitional support. Thank you.
Hi, my name is Jody Brooker, and I'm a behavioral therapist, and I work on the neuropsychiatry ward. But we also have outreach that would provide similar services to what you do, but support families, to support clients, whatever it is that's needed within that, and help everyone understand what the function of the behavior is. So through data collection, what can we do to mitigate that issue and help resolve what we could? So along with the team, the care team, the nursing, PCAs, however that looks. So, yeah.
Hi, I am Angelica Germanis, a recreation therapist here in Ontario Shores at the Geriatric Dementia Unit. So my role is to assess the patients, to find out what are their skills that they still have, what are the needs, what are the goals that we can provide some leisure activities that they could have quality of life to maintain that. And usually part of my assessment is to observe them some of the activities that happens, such as reminiscing groups or baking, and again, based on their hobbies, their interests, we will find the right activities to engage them, something that is meaningful for them. And the family are a big piece to kind of share and pass their information to us, especially when we can now kind of interview the patients. So we will have a lot of activities planned for the whole month, so and families are more than welcome to come and join and be involved with the patients also. So. The activities actually happen in the ward, and there are some activities off the ward. So, yeah, there is a schedule for the whole month, so what's happening daily. Yeah.
We share the same role.
All right. So this is Carolyn, and I'm Cindy, and we're nurses on the Geriatric Dementia Unit here at Ontario Shores. What we do here is we take care of loved ones that are admitted to us that have dementia-related behaviors that are no longer manageable in the nursing homes or wherever they are living. And our goal is to get them back to where they are. So we'll do our assessments to see what interventions we can prepare to help them out so that they can become manageable back at their nursing home or back at home. And then we provide support to the families as well.
Thank you.
So I work in geriatric psychiatry. I work really along the spectrum. I work with people like Debbie. I see people in their homes when a nurse clinician need some assistance around more specialized assessment or diagnosis or recommendations around medications. I go into nursing homes and see people in nursing homes, provide consultation to family doctors, either by seeing their patients or by talking to family doctors over the phone. And I do a lot of my work on the inpatient unit here as well as some specialized clinics. So.
I think we're supposed to be commenting on how to create smooth transitions of care, and it seems to be obvious that we need to understand each other's roles in order to be able to make those transitions. That's my comment as an observer.
And then our system level.
Hi, I'm Stacey Hawkins. I spoke earlier. My job, I'm a clinical planner with Central East Regional Specialized Geriatric Services. So quite appropriately, my job is to look and see what's happening with this individual and her family through all of these different points and try to make recommendations on how to improve those transitions. So those cross points between individuals and providers, including which is not represented here, primary care and hospital care.
Hi, I'm Karen Lee Bolton. I work as a quality improvement facilitator for the Central East LHIN.
on a behavioral supports program. So I'm a component of what Stacey just talked about as we're looking at all services for seniors, but we're looking specifically at responsive behaviors and looking at the whole system in which we work and what the gaps are in the system, where there could be redundancies, and we're trying to eliminate waste and make the connections smoother. Simpler steps, more straightforward for the workers in the system to navigate, as well as families and caregivers and patients as well.
Thank you. Do you feel as though, based on this continuing care, that you have a better understanding of some of the services that are available to your family member?
Absolutely. I'm astounded that all of this exists. I had no idea. My dad had been here in Wiki and had mild dementia for over 4 years. So.
Thank you all very much.
Now, I'll be very brief and run through the slides because 95% of the work has been done for me already by you all. You all, instead of me just having it here up on the slide. But one care provider that was missing here was the family physician. And they're often the initial point of entry to some of the services that were mentioned to you today. Oftentimes, we have found that the family physician makes multiple referrals because they're not certain who to refer to. A part of the reason why I did this exercise was to highlight the importance of us having an understanding what services we provide as individual care providers, and also the importance of establishing a seamless continuum for the individuals in need. So just very quickly, what I'm going to do is just share with you a patient's journey. So Betty is a 75-year-old female. She lives in Durham. She was referred to the Gain Clinic by her family physician for psychotic features, depression, cognitive decline, and functional decline. So the Gain Clinic, all of you will have access to all of these slides, in addition to having in your package a pamphlet for all of these services that I'm going to be mentioning in the slide. So I'm not going to get in detail. So basically, the Gain Clinic is a geriatric assessment intervention network. And it's 4 clinics that have come together, and basically what their role is to do assessment and treatment as needed, and their mandate is to keep the senior from being hospitalized and to provide treatment for them wherever they are. So Betty was then referred to Ontario Shores for diagnostic clarification. So she came to Ontario Shores. She was seen in our memory clinic, and she went through a battery of testing, including cognitive testing, and that was where she was diagnosed with Alzheimer's. She received some interventions, some recommendations, and also some medication. So basically, our memory clinic has an interprofessional team, and that team consists of geriatric psychiatrists, behavioral neurologists, a neuropsychiatrist, geriatric psychiatrist, occupational therapist, and a social worker. And as I said earlier, there is a pamphlet that gives you a lot more detail around our memory clinic. And basically, our memory clinic does not provide follow-up services. So what we do is right away for every single patient who's seen in our memory clinic, whether they get a diagnosis or not, they have a referral directly to the Alzheimer's Society, which provides a first link program. And that's where they provide a lot of education for early diagnosis of Alzheimer's. They also have a referral to CCAC accordingly. So from Ontario Shores Memory Clinic, Betty was then referred to CCAC, where she received occupational therapy home assessment, medication compliance support, day programming, and PSW support. Now, CCAC provides a gamut of services, but those services were selected specifically for Betty to provide the individualized care she needed based on her medical and cognitive needs. So Betty was also referred to the Alzheimer's Society of Durham region, where they provided a lot of education and family support. And then you heard a little bit earlier about the Alzheimer's Society and some of the services they provide. But the First Link program has proven to be a value add in terms of getting information and education to the family very early in the process. Then Ontario Shores referred Betty right back to the GAIN clinic for ongoing follow-up and treatment. So I don't know if you're getting I think someone had mentioned earlier that they didn't realize that there was programs available for the family member. So there is quite a lot of programs available, whether it be for the family member or for the patient after diagnosis. And then Community Care Durham is a community support service, and they also provide transportation, Meals on Wheels, PSW support, and they were also referred to by Ontario Shores. PCSP is a psychogeriatric community program, and basically the GAIN Clinic, Ontario Shores, and PCSP has come together to provide a shared care service to ensure that we are providing care to the patient with dementia wherever they are and trying to minimize hospitalization at all costs. So the demonstration that you saw creating the circle of care was one thing that I think that we're doing much better today than in the past, is coming together, but getting a better understanding of the individual service that we provide and trying to ensure that we establish a continuum of care. And then Dr. Fischler spoke earlier to some of the service that we provide here at Ontario Shores. We have a mood clinic. We also have the geriatric outreach team, which you heard one of the representatives spoke to earlier. And then Dr. Fischler gave you a very good and in-depth information about our geriatric dementia unit. And then this is just a couple of referral points. As I said earlier, the initial point of contact would be the family physician. Then they could refer either to GAIN or directly to PCSP, and then both clinics can actually refer to Ontario Shores. But the important thing is that we're trying to avoid duplication right now in establishing a circle of care. And then appropriately so, if a severe depression is identified, for example, we do have the memory clinic here at Ontario Shores. And then our geriatric memory clinic is where the dementia, where we do the diagnosing of the dementia. Betty was then I think that the picture that we want to portray here is community partners and the importance of working together and helping the patient through a seamless journey. So Betty was supported from the very beginning, because I believe that the family physician had an understanding of the services that were available in Durham region and knew exactly what point and where to refer the patient to. And then the seamless care was demonstrated by the referral source. She was able to receive an accurate diagnosis, which led to the administration of the needed medications that she required. All the appropriate linkages were made in the community. The multidisciplinary team was provided to her at various junctures, and Betty is still at home with her family. And they know the family is comfortable in reaching out appropriately based on her needs. So I showed you this picture before, and I don't think that we're exactly there in terms of having exactly the seamless care, but I think that we're getting there. We've come a long way in terms of ensuring that the right path for the right patient at the right time is put in place. Thank you.
Well, thank you for that live demonstration. Very good. We're on time, and we have some time for a few questions.
I just have a comment, actually. Community Care Durham houses two programs,
Oh, sorry, you need the mic. I'm sorry. Sorry about that. No, that's fine. That's fine.
I'm sorry. I should have come up to the circle because Community Care Durham houses two programs called Home at Last and Access to Primary Care. Home at Last transitions seniors from the hospital back into their home. That's right. And Access to Primary Care will actually help take seniors to the appointments, especially the GAIN clinic, and it's all funded by the government. So.
Thank you. And you'll find that in this pamphlet here, which is in everyone's package also.
It can be a referral through the doctor. It can be referrals through the hospital, or also self-referrals.
There's a question
here. One of my biggest challenges is dealing with the long-term care homes when they have a lot of residents that are 50, 40 years old and developmental delay. So we have a developmental delay. I have a 57-year-old man that's 375 pounds, bipolar, schizophrenic. So he's bouncing between inpatient stays, and then there's referrals here to Ontario Shores, and they say, oh, he's 51% medical today. He belongs in the hospital. No, he's all behavioral. He belongs in psychiatry. And it's one of these people that just falls through the cracks. And unfortunately, I just find the developmental delay population is really hard to serve once they get elderly. And we know that they age faster. Those people that are in their 50s are often aging maybe at someone who's 65 plus.
Right.
And so I don't have an answer, but that's one of the challenges I've had in dealing with helping people in the long-term care homes who have developmental delayed residents.
Yeah. Thank you for sharing that. And I think that these types of cases are increasing, unfortunately, and as you said, are falling through the cracks. I think that these are the cases where the various sectors need to come together and have a case conference. And I think that this is where we need to have the conversations collectively to determine where is the best place for this individual to be treated. I think that, there was one of the representatives who shared their geriatric mental health outreach services. I think and the mandate of outreach services is to bring the care to the patient to avoid unnecessary hospitalization. So I think that in those circumstances, we can have the case conferences, and this is where you bring the professionals in mental health out to the individual and have those consultations. So, most definitely, that's the nature of business that Ontario Shores is in. So, to me, that would probably be an appropriate referral to Ontario Shores for outreach.
Would that be into the neuropsychiatry unit, or where in Ontario Shores?
Well, we also have a dual diagnosis service here as well, right? So it could be for dual diagnosis outreach, or it could be for psychiatry outreach.
Hi, my mom spent 2009 to 2012 in a nursing home in Whitby, and she passed away on Christmas Day. My question is when a resident of a nursing home goes into the hospital and then they have to be transported back to the nursing home, is the nursing home not responsible for providing them with that transportation, or can the Home at Last program be utilized? Like, for instance, my mother, between June of 2012 and December 2012, she must have gone in and out of the hospital at least 6 times. And the hospital kept coming after me and my sisters and said, well, I'm sorry, but you're going to have to find a way to get your mom home or send her home in a cab. That's exactly what they did. I tried to contact CCAC and to see if they would assist every time she needed to be transported out of the hospital, and back to the nursing home to see if they would arrange, those ambutrans or something like that. And several times that I did that, we were told that we would have to pay a couple $100. And I feel that if my mom was provided with better care, there could have been a good chance that she could have maybe survived another year. Okay. But it's the transportation issue. It didn't only happen with me. It happened with other residents and families in the nursing home my mom was at.
Okay. First of all, I want to acknowledge and my condolences for the loss of your mother. I'm also sorry, actually, for the system failure that you experienced. But I think moving forward, collectively, that circle that you saw there needs to assist to avoid those type of issues moving forward. I did see someone from Community Care Durham sort of raise their hand to respond to the question about Home at Last. So if we can get the mic to her, that would be great.
As long as the patient is a one-person transfer, Home at Last can take them home from the hospital numerous times, as long as it comes from the hospital, the referral. And if they are wheelchair-bound, we need 24 hours notice from the hospital, and we can arrange Blue Line.
Yeah, my mom was wheelchair-bound, and each time the hospital
Sometimes it just takes us to be aware of what services are available, because not everybody in the hospital can know what is available, but we are fully available.
before she even went into the nursing home not myself, I spent the last 2 years of her life before going into the nursing home trying to take care of her, and family doctors and CCAC, family doctors and CCAC, when she was still living at home the last year before going into the nursing home, never even told us about the services that were available, for me to help take care of her, which is unfortunate. All that you guys were talking about up front, I didn't know you were out there. Yeah. Unfortunately, my mother is one of the seniors that did fall through the crack of the system, and I can just kick myself for not trying a little harder to look after her.
But we do thank you for actually being here and participating in system improvement, because I think that that's exactly what this symposium and this particular topic is about tonight, is so how we can improve the system and fill some of these gaps that we're referring to as cracks tonight in the system.
My question is, you were mentioning about the outpatient services through Ontario Shores. Are those outpatient services just for individuals from that are in the hospital and then moving out into the community?
No, they're not. They're not just solely for our inpatient population.
Okay. All right.
So referrals can come from your family doctor or your family yourself. So there's a 1-800 number on the website. Actually, right in the pamphlet here, at the back of the pamphlet, you have the access number for the website. So we have a centralized referral, and when you go on the referral, you have the individual services that you can refer to.
Okay, thank you.
Okay.
Well, thank you, Sheryl.
You're welcome.
Thank you
My
so
pot
much.
of gold.
Thank you. Yeah.
Thank you.
And thanks to all of our participants and speakers today. Thank you so much for coming. Thanks for your illuminating questions and illuminating talks.